Boa tarde a todas e todos que estão aqui conosco. Eu me
Good
chamo
afternoon to all who are here with us. My name is Gisela Carrillo. I am a nutritionist, doctor in public health, and consultant from the General Coordination of Nutrition and Food from the Department of Promotion of Health, Secretary of Primary Attention of Health from the Ministry of Health from Brazil. And I will be moderating this third day of the seminar in primary health care. Today will be the last day of the second seminar, to which we have been giving a great many times for us to talk about this issue. So this is an initiative from the Ministry of Health from Brazil in partnership with PAHO. Remembering that the event has simultaneous translation for English, Spanish, and Portuguese, which is being broadcasted at real time at PAHO's website, YouTube channel. So please access for just to see the first day and then the second day. So the matrix for care in primary health care, the recommendations to strengthen nutritional attention in primary health care in Brazil, and also the window of knowledge for food and nutrition in public health. All materials are available in the website of the seminar, nutriçãoaps.com.br. Today's program is about the theme of interprofessionality and popular education for food and nutrition in primary health care, as well as bringing international experiences from Spain and Portugal, and also Trinidad and Tobago, and nationals from the Brazilian states of Minas Gerais and Pernambuco, which will be shared about the challenges and perspectives about the policy for food and nutrition in the context of primary health care. We remember that our team will be looking at the chat during the event to see the comments and the doubts were being made. We also take this moment to thank for all the contributions that were received in order to build, to construct this second letter in Brasilia, which will be a greatest delivery for this seminar, which will bring propositions to bring the actions for food and nutrition to make them a priority for public policies and to guarantee the universal coverage for actions in nutrition and food in the health system. So just remember that we're going to read it in the end of this day. So now I'm going to ask for the coordinator from the Ministry of Health in Brazil, Dr. Gisele Bortolini. Hello, good afternoon to you all who are here with us. We are in our third day of intense debates. Yesterday, we had the opportunity to discuss humanitarian health, nutritional and food safety, the human right to an adequate nutrition. We also had the experiences from other countries like Canada and United Kingdom, and also Brazilian ones, which left us very proud and also emotional to see the experiences of Palmas with Fernanda and Curitiba with Patricia, which is our SUS, Unified Health System Helping in Practice, and this reaching people, which is our greatest objective, that SUS can be more inclusive, to be offer more things, be by guaranteeing access. So these experiences make us very proud, and now we are gonna have many others from other countries and also Brazilian ones. So thank you for your presence. Thank you for the panelists who are here today, Maria, Mariana, who are our partners here from the National Council of Health and other bodies. I wish you all a great debate now and then the experiences from our other countries. Thank you very much. Thank you, Gisele. Now we are going to begin with our first table of the day, which is called Interprofessional Education and Popular Education for Food and Nutrition in Primary Healthcare. To deal with this theme in the context of care and food and nutrition and primary healthcare, we invite Dr. Marina Peduzzi, which is a nurse and doctor for collective health from a university in Campina, a doctor's in education. in the College of London from the University of London, an associated professor from the Department of Professional Orientation from the Nursing School from the University of São Paulo, Dr. Marina. You will have 30 minutes for your presentations, and when we have 5 minutes left, we are going to tell you. So welcome and thank you very much. Thank you, Gabriela, for your words. Thank you for the invitation. Congratulations for this second seminar. We have with a very important theme, food and nutrition in primary healthcare, which is very important. I'm very proud to be here participating in this debate. Please, Vinicius, put the next slide. So I had a content with the products that Gabriela said, for the matrix, about the cares, about foods and nutrition in basic care, and the results of her studies, which were done with recommendations. So I'm going to start from that because one of the dimensions that appear, be it in the matrix or recommendations, it is the workforce. So the workforce is about the workers, healthcare workers, and especially to the healthcare professionals, the healthcare providers. We are all from this area, including people from safety, and these healthcare professionals, they are workers that have a specific education in the health field, like dietitians and all the other professions. In Brazil, we have around 16, 14 teams of education defined by the Ministry of Health, and now we have undergraduates in collective health. So from the health professionals, and not only for a graduate level, technical level, undergraduate level, and technical level, when we are talking about the workforce, it is for all of them, be it from safety. Well, since we're thinking about care, about nutritional attention in the primary healthcare, then I thought it was interesting. One of the axes is to think about the workforce, professionals, and then there are three elements which are very important to provide them, and if the education. The next slide, please. And I'm talking about this because this theme of interprofessional education and the interprofessional practice, it is about what in Brazil we call the management of work in education, which is a new name which will substitute what we used to call human resources, although human resources is a word that is still used in Brazil, but now we have a tradition in this construction of SUS and public health, collective health, to think from the management of work, since we are talking about the professionals, and the management of training. And this theme is within this part of this place. So it's what the seminar is discussing. So when we think about the professionals, what do we want? They need to be there in a necessary number. They need to have a good quantity in a good place with the good education and performing pertinent actions and dealing with the things that they need to deal with. Oh, it's very simple to think we need to have a dietitian, physical therapist, a doctor, nurse. Yes, but they also need to be planned in the adequate place, in the adequate environment. So how do you think about this? What is adequate? What is necessary? It is overall the consistency, the correspondence between the healthcare necessities of users, families, communities, territories, with their own characteristics, the conditions for work, and the public policies that exist. So it is from this correspondence between these elements that we can have a planning and think about this provision of professionals that are necessary to strengthen this care in food and nutrition in basic care. Another important component is the work procedure. So the work procedure, it will talk about, please, the next slide. This work process for the care with food and nutrition in basic healthcare, is about something that is very important for us when we think about SUS, which is the change in this care model. So this care model that is centered in the curative action, hospital action, biomedical. Biomedical reference is very important, but is a concern when you think about a model that is strictly about biomedics. But long ago, we have been doing a movement to be the integrality of health. So when we think about integral care, we are thinking about a perception of the healthcare necessities, the concerns from the population, which contemplates also the vulnerability, social ones, and the determination, subjectivity, intersubjectivity within this communication. Another aspect that I would like to highlight very fast here about the changes from the work procedure, I had the opportunity to orient a person that was doing a master's degree, which is a dietitian. It was a pleasure, a great opportunity to learn a lot. And she produced a study, a revision of an scope which is public, a review in the scope in which she investigated how to implement the nutritional conducts, be it in nutritional care, oriented by evidences and not only by studies, clinical studies, but also the public policies and in primary healthcare. So from this invitation, I went to the production of Tamara de Oliveira. And it is interesting that when she did this review, an intense review that began with 5,000 titles, and which was very interesting, the procedure, and she actually noticed that in order to implement these conducts, the care, nutritional care and food care, oriented by what we have in knowledge and what it's better to be done. An important thing for the implementation is to know the needs, the healthcare needs, and the local reality, in which is life and work of the users, families, communities, as well as the necessities of the services. So it's again looking for the care of food and nutrition in primary healthcare, which needs to know the reality of the place, to know the necessity of users. Another important aspect it was identified in this study to implement this conduct was education and support that professionals need. We have a very reduced number, limited number of dietitians in primary healthcare. We need to amplify. That's why it's good to have that provision. We need to think the dimensioning of people and from the necessities of the population to also have a number of professionals, specialized professionals, which is greater. So beyond that, the dietitians needs to it supports the other professionals so that they involve themselves in this care, like it is done with a nutrition. So you do the support, specialized support via this education. So permanent education and the education within the initial education when professionals have more contact with these needs and with elements that can later recognize and answer to them. Another element, important element, is the monitoring and the working team and interprofessional practice. The issue of interprofessional education and the practices, collaborative practice, also appeared in the review from this literature, which we're talking about the implementation of these conducts of care and food in primary healthcare. So now thinking specifically about what we are talking about here in order to discuss with you in this table about this working team, collaborative practices. Next slide, please. One thing that I would like to highlight is that the theme of this working group, interprofessionality, and when we talk about interprofessionality, it is complementary to the interdisciplinarity. It's not that this is something that is leaving, but interdisciplinarity is about the needs very closely to teaching, education, and research, because it is all the effort to integrate in the knowledge areas of science. So it's very important that this education and permanent education also deals with the development of elements, resources, and competences that help to promote the integration with the many different practices. So this healthcare services, with its great complexity in the healthcare field, which is growing, and all the vigilance work, not only internally, but also all the attention to health, all SUS, it needs, and in many actions, that the intervention is interprofessional, that involves different professionals, and that they can act in an integrated way, articulated way, with collaboration. This is an old theme which is being discussed since the 60s, but it gains a lot of highlight in the last 2 decades. So since 2000s, we take this more intense discussion about the collaborative practices, this interprofessional education, because there are many studies. Some studies are not concluded. We are still far from having a lot of scientific evidences which are conclusive, but there are robust studies that show that the collaborative work, integrated one between the different areas, they collaborate to improve the population's access to the security of the patients and the quality of attention, especially the patient securities. There are many studies that show that the greatest part of the adverse events of the medical errors in all healthcare professionals, they have in their roots the difficulties to communicate between professionals and teams. So professionals do not know how to talk amongst themselves, do not know how to integrate, and this creates serious damage to patients, even leading to death. So much of the accidents and the adverse events and all the debate of the patient security is also about this issue of the difficulty to communicate in professionals. And this, in the last 2 decades, this debate is strengthened in order to, because the tendency is to go to this side, and the complexity is present, and we have the compromise to meet it to the many Brazilians and to assure healthcare conditions to them. In fact, it is very important, the expertise of each area. And in this seminar, we are talking specifically about nutrition, but it's very important to articulating the integrate professionals, dietitian professionals, and other professionals. So when we talk about the interprofessional work between the different areas, many authors which are discussing now a model that the work in the team, it is diagram. This is a small nucleus, which were the professionals years ago. The action of health is due to the action of the professional. We know nowadays that the professional's action isolated in an isolated way does not reach good results. So the small unit of producers starts to be the teams, the small teams. When you talk about team, we're talking about the small joint of people that has the responsibility over itself of a certain joint of people and communities. The teams have under their responsibility many users and patients, be it in hospitals, in an be it in basic units, be it in the surveillance, health surveillance. The teams have a responsibility for a certain number of population, certain groups, certain communities and users. So these are the teams. The teams cannot deal with all the necessities. They need to work internally with collaboration, but they also need to collaborate beyond the team. That's where we go with the last year alongside this working team, this function of the collaborative practice. Collaboration, it is necessary to collaborate amongst professionals and also the teams to collaborate amongst themselves with teams and services from the network. This is a diagram. It reaches there in this network work. The collaboration is in the system. It begins inside the small teams, but it goes beyond that. It goes very far beyond to the teams. Next slide, please. So how do you produce this working group and collaboration? So very generally, because this is what the nutritionists, all the professionals, giving this nutrition, and the support and the planning and in the attention and the care, nutritional care. There are many actions, complex actions that develop themselves throughout the network, here specifically in primary care, and the dietitian works with other professionals. And how does this integration work? An important thing, which I already referred previously, is to know the profile of user and the population which is taken care by those people, which is taken care in that region. So all the planning, all the organization is from this reconnaissance, the cognition. So they work with this logic, epidemiological one to know, but each team actually needs to prepare themselves to work in this perspective with a population that is there. So knowing the profile of the user and population is fundamental, and from this recognition for the necessities of those users and families, communities, to define in a shared way common objectives. Which are our priorities? What do we need to give priority to? The teams need to define this in a shared way of the objectives, to monitor the actions that they perform, to be sure that they are walking in that perspective. This goes beyond the teams and services in the integration of the network. There is an entire logic, collaborative logic that is there, but it begins in those big small groups, that's those small work groups that I said before. And a fundamental thing too for collaboration, and here I understand collaboration what? Collaboration is not, oh, we are fine with each other. Collaboration and interprofessional collaboration means that professionals want to work together. So dietitians want to work together with the community agents, with physical therapists. We want to work together because we know, we recognize that together we are going to have a better care. We will produce better results for that community, for that population, for those users. We're going to produce and care that is very more interesting and that meets the necessities of the people. So collaboration is this, to want to work together because we know that together we will produce better cares. And this collaboration that is within the teams and all the service, the network, it goes through many vehicles and tools. So the communication is fundamental. We know that healthcare professionals, we learn to communicate with the users, with the population. We don't even learn to work among ourselves. There is a great difficulty, like I said before. This is behind all the difficulties and the security safeties from the patient. Professionals don't talk amongst themselves. Of course, there are many other problems about the hierarchical relationships, of a recognition that is unequal of the works of the different areas. There are many other problems, but we need, be it in the practices of health and in the education, like I'm going to say later, we need to invest in developing competences for the communication between professionals. So how can I talk to another profession from another area? And this is not to talk in a critical way, political way. It's just to say, no, I don't believe in this. I believe that the user needs another thing. So now let's talk to see how to work this out. It seems obvious, it seems simple, but this is very difficult to be done in the teams and amongst professionals, health professionals. So the communication, interprofessional communication, be it in the attention centered in the user. So there are many elements in which we call the competences, collaborative competences that are developed in order to be able to work in a more integrated way, articulated way, collaborative amongst the different areas, because we know there are evidences that the nutrition area has a great contribution and produces a lot of research showing that this has an impact. And another fundamental element for us to advance in this work group and collaborative practice beyond communication, interprofessional and the communication with users and the population. It is to promote the participation of the users, of families, communities, and territories. It is primary attention. This territorial approach is very fundamental. In this field of food and nutrition, the care, nutritional care, it is fundamental to think about this perspective. And this needs the necessity. It's necessary to have a participation. So this strengthens when we discuss working groups, collaborative practice, we highlight this a lot. The users, their family members, and the population from the territory need to participate in the decisions. The user needs to participate. So they will involve themselves in that proposal to care and segments that are being done. Does it have a condition? They need to decide this amongst themselves. So the user needs to be consulted, the family too, the territory, certain measures, educative measures. Maria Claudia will bring later the discussion, the fundamental discussion that popular education has. So all of these requires participation. So about this participation that I talked about and many other elements. Next slide, please. And the third component from the one that I said before, we're talking about the workforce professionals, the composition of teams, the work procedure, and now the education. Education and for professionals, healthcare professionals, needs to contemplate the development of competences, knowledges, practices that are about the nutritional care, that are about nutrition and food. So it is very important that the education, be it from the beginning in the undergraduate level and all the life of the education of the health professionals, be it professionals who come from education, professional education, technical level, or the higher level professionals and in permanent education, that this is permeated in certain moments or what we say interprofessional education, because this is another concern. We develop a practice, we do an education that is general and uni-professional, let's say, so only the dietitian only talks about with other dietitians and the medicine only with other medicine doctors, and this goes for all areas. We have a uni-professional education. The permanent education is basically uni-professional, and we need to integrate. When we talk about an interprofessional education, we are thinking we need to integrate elements from the interprofessional education in the education, be it in undergraduate level, be it throughout the lives. Professionals develop competences relative to their field. So it's not a specialized formation. The field are the knowledges and practices that are about health as a whole, but they also need to have experiences, learning experiences, that this is going to develop what we're going to call the collaborative competences. Interprofessional communication, the attention centered in the user that is present in the construction of SUS, all the 30 years, 32, 33 years of the construction of SUS goes through the emphasis in the reconnaissance of the necessities, the orientation of the system through the necessity of users and through the centered attention. Another domain that is very important that I'm calling about the collaborative competences, which is interprofessional education, which proposes itself to collaborate in the development, is the recognition of knowledges and practices from the other areas. We know little about what other areas do, which are the technologies, the techniques, the contributions, interventions from the other areas. And if I know what the other area does, I can integrate with what I have in my knowledge and abilities. So this recognition of the role from the other areas and or the knowledges from the other areas is fundamental for collaborative practice in this interprofessional work, the work dynamics to working group, which is necessary to have the abilities to do that, leadership, collaborative leadership, and management of interprofessional conflicts. So this is a Canadian model, which is from 2010. It is being reviewed now. But there are 4 models of competences, collaborative competence, and we have been using a lot the Canadian model, which seems very interesting. They are very similar because to the American model from the United Kingdom and Australia, and we have been working a lot with this model. So when we talk about interprofessional education, what are we talking about? Next slide, please. The interprofessional education is about to introducing experiences, initiatives, actions, interventions, educative interventions throughout the education, and then permanent education through which members of more than one health profession learn together in an interactive way. But it's not everybody staying in the same classroom watching the same class. Is that students from nutrition learn and discuss cases, do these house visits with students from other areas, or maybe physical therapy, psychology, social services, nursing. So the interprofessional education is the presence of actions, initiatives that make it possible that students or the professionals to learn together with the other areas, because it's working together with their friends and students from other areas that I'm going to know, in fact, what is the other area, what the other area does, what makes a dietitian and what makes a dietitian a doctor, and how do we integrate this? How does an action have an idea with the other? And when we have this experience, this interactive experience to know with the other and in an explicit way for the proposition to develop knowledge and abilities, multiple abilities that make it possible to have this domain of tools to mobilize in the necessary moments and involve themselves in the work team and collaborative practices.
The idea of competences, and I'm closing here my presentation. Thank you. So it's in this respect that competence is the group of resources that the person will need when necessary. So in this manner, I think that I can end. It took. I still have 3 minutes. Okay, all right then. But I believe that we can end on this note. That's what we were doing. We about talking and the nutritionist of strengthening the nutritional care in primary health care requires an interprofessional work among the different areas in which the nutritionist, there is a specialist that's going to help plan and guide, but he won't be able to take care of everyone. He has to integrate with the other professionals, and that also requires some actions in this respect, which is what we call the interprofessional education. And its main characteristic is the intentional aspect and the explicit purpose to work in a team and to develop collaborative practice. It should be explicit and also in the professionals in the different areas that can learn in different areas. That's something that these are some interventions that we need to learn. The specialist is going to continue be specialized. They will still be nutritionists because there is a major contribution of all the areas, but it is important to integrate in this permanent education, experiences and initiatives and opportunities for this learning, which is interactive with professionals from other areas. Thank you very much for the attention, and I'm here willing to available for the debate later.
Muito obrigada, doutora Marina.
Thanks a lot, Dr. Marina. I believe that you bring important elements for the reflection concerning the interprofessional education and mentioning the access that were talked about in about the need of different professionals and concerning the process of work as well. And it connects to what it is at the core, which is the education and training, professional education and training. And that's one of the justification, the reason for this professional education to happen. It is one of the reasons is that together we can provide better healthcare of better quality. And also the isolated action doesn't bring necessarily the same results that the territories and the families and the users need. So we thank you very much. And I believe something else that you mentioned, and we can think here that is important, is the capacity to talk and to communicate. And you mention it as maybe a challenge that we still have to overcome and work on so we can improve it. So we do thank you very much for your contribution. And now let's continue to the panel. So we're going to continue to the panel talking about the topic food and nutrition in primary healthcare from the perspective, popular perspective. And Dr. Maria Antonia Cláudia Carvalho, nutritionist, doctorate in health in collective healthcare by the University of Rio de Janeiro, and postdoctorate in the program of post-graduation and communication of the ESPM's College in São Paulo, and associate professor in the Institute of the Federal University of Rio de Janeiro, and coordinator of the Digital Lab of Digital Food and Humanities of the Federal University of Rio de Janeiro. Doctor, you're going to have half an hour for your presentation, and when we get to 5 minutes, I'm going to let you know. Thank you, Gabrielle, and everyone in the event. I'd like to congratulate you for this initiative. With such a robust work, the effort and the difficulty which is to hold an event to prepare the materials. I'm considering the materials in my presentation because I think that when a material like this is available, I believe there is a consensus that we can work with. So I'm already taking it into account. But I'm going to work with the most popular, more popular part of this primary health care in nutrition and food. You can go on, Vinicius. That is an image of the material, but I'd like to highlight something important for us to work with. That is the integration of this with SUS, because the unified healthcare system is unified and unique, and it's going to encompass as many differences and peculiar aspects that is very specific of each region. And we're going to have to deal with this world that is more macro. And that's why it's important for us to talk about now, which is the region, the destination of the work, which is of what what everyone has to say or to do, sorry, work, and where we want to get our destination. And we have what we have as a reality in each region of services and professionals are available, and trying to bridge what was presented before. Marina mentioned this intentional aspect and this team. This includes these differences. Okay, you can go to the next slide. And so we are not going to work with the political aspect, but the political aspect is within these small rules that are part of this educational process, that are part of this pedagogy, the way to understand how we're going to live better. So this universe is a universe that is connected to, I'm mentioning human sciences here. So we can establish connections with these thinkers that help us understand and to get these links between this popular education. I believe that the first thing I want to mention is the idea of the human sciences or humanities. It has a difference in classes and different in social classes and different consumptions as well. There are two different bills that reflect two different financial systems that are very different and are going to that encompass culture and social groups that are very different, such as which is euro and the Brazilian real. And we'll have to think and to consider the differences between countries, differences between social classes, social groups, and the types of consumption that are also different between the same class, within the same class, and within the social class, a group, a state, or a region, or a small region, or small teams such as what was brought by Marina in the examples mentioned by her. And that is the place that I think we can say what is popular. So that is a universe that is stratified. And I'll look at this universe, which is the popular one, and I'll try to find within this reality that we have in the world, in Brazil, in each corner of the country where we are, in this world and that it's so full of inequalities, but from the perspective of strength, a perspective of these different consumptions and different classes. I'm sorry. There is a strength within these two, and this is the strength and that we have to work with today. This one here is a picture of principles and nutritional education and that are connected to these ideas that I'm mentioning, so we can think about this universe. What's most important is for us to think what human being is within the SUS. So this strength and the capacity that we have to rebuild and to interact and to integrate and to appear is something that we have to think about because it's within the primary healthcare services, because it's a situation in which we have more responsibility with the healthcare, and we have to try and generate within these environments and these spaces and to deal with something that is very complicated and consider and which is a challenge, and to follow a path that we might not do. It's considered that it's considered negative. So the positive aspect has to come from the reality. That's the idea that we have to work with today. What is reality and how to understand, how should we understand this reality to think about the interaction between these different actors in these different social classes and different types of consumptions that they have, because we're talking about a differentiated social group, and I'm asking you to think, what is this group? Where is it? How does it relate to other aspects, to other groups? So this is a universe of different stratified system and different consumption. So the first point is the cultural one. So you shouldn't fight with the differences between these two groups. We should use culture as our ally. So then we are going to have to negotiate very much. Why? Because we want to change a lot, and a lot of things we don't want to change. So if we manage to look at how people get food and to interact with other people, the teams that are more open, the capacity of communication, the services that are more capillary, and these cultures and these ways or manners of living, They have to be in our favor. We cannot try and want to change them because there has to be something within culture that will help us. And now we are in a relationship with culture that we have to value it, not to they take it for granted. So something within this culture we have to value because that's the way for us to get close to it and to work with these different places and to deal with these different types of consumption. So the idea that Mary Douglas brought us, I'm bringing some pictures here and talking about them. So we have an idea of bricolage. What is bricolage? That is a word that is very common, but I wanted to use it in the respect that we know that for population to survive, this population uh, deals does something to deal with reality, and this creativity is something that the us we that are in the professional side we shouldn't change it. We don't have to change it every time. You can go to the next one. And they are different aspects in which next one. Yeah. And this understanding deals with this dialogue. So in this picture that we have a metaphor of the pasta and sausage that in school is preferred but in a very large amount. That's not what we want. We want vegetables and we want family agriculture. We want variety. How are you going to dialogue with that? Not always difference is something that we can deal with easily, but these conversations are going to make us mature, and that's where the educational process goes in, which is a process of respect in favor of change, but a change that it has to be made in as an agreement between all of the agents and stakeholders. So so that's the idea, we're working with. This process is the one I'm calling bricolage or do-it-yourself, which are mixes or workarounds or things that have been used before to be used for something else. To use maybe fruits or for this Brazilian type of lollipop or popsicle, okay? And that is the idea to be connected or allied with culture. And here we have a picture that is very often mentioned here, which is tell us to value the regional culture, regional culinary, or dishes. That is a very common dish in the northern region. And that's something that we value. So this is considered within our policies and our guidelines that we are following. So we have Punky, PNC. They are valued also. That's something that within the universe of healthcare is maybe taken for granted, and now we're valuing it, and people didn't even know or weren't aware of it, and nowadays the media and some people. Next slide. Which is this kind of corn. You know, the corn that is not completely yellow, that is indigenous and Guarani tribes. And we don't want to lose it. We don't want to lose the diversity to have the standardized corn that is industrially in large scale is produced that might bring us few advantages and some problems. In relation to the changes that we want, uh, if there is no problem in this respect, we need to have different works and we need this culture and negotiate with it. So considering this division of brands that are ultra processed, that are going to homogenize the whole world, the way to eat, it's a very globalized and industrialized and processed way of eating. This is also culture, right? That is a global culture. It's a contemporary culture. It's a process we're living in. You cannot say that this is weird because people get fed this way or they feed themselves this way. But within this kind of culture, we can negotiate certain aspects using reality. And that's what Mary Douglas mentions, the consumption that we're going to have to reflect on and we're going to understand better. This integration, we already have it in public policies. We have this effort that was started and the materials that are propagated in this seminar. We do have this regional foods that are valued, and we know that this bridge is a bridge in Sul, so you can go to the next slide. Let's go a little bit faster. But we
Oi.
have,
Não, só para dizer que tem 15 minutos ainda.
I just wanted to say that there are 15 minutes left. Yeah, because there is a lot, okay? So we have to transform hunger in, the changing of hunger in a social symptom. It's this is within the system. It's in this group, the organization that is going to cause this problem. So it's no use just saying, "Oh, there's someone hungry, and we'll provide them with food, and we'll solve this problem." And that is a structure and a process that we have to think about. Let's go to the next one. And mentioning here José de Castro, so we can think about the issue which hasn't changed much, because Josué de Castro mentioned it in the past, that hunger is a social issue. It's not a matter of having the means of production. It's an issue of distribution. And Milton Santos too mentioned this idea of the space that broadens this discussion, and we've been working with that. And this work, I see more and more people having a more creative notion of territory and space. But it's also too important to think that the space is also connected to the internet and social media. Uh, and as José de Castro mentioned, this geography is amplified from the physical aspect to a human space. And that's what we're talking about, the social classes and the type of consumptions and how they relate. This universe, along with social media, it's mentioned in this respect. I want to bring you a challenge. So the a person with very small means has a cell phone, because this type of device gets to classes D and E. So the network and social media and the other possibilities, I want to bring us this challenge for us to consider what is the people, what are the people in a space that has more connected to social media, which is not easy, but we do have to connect to it, to this way that is popular, and maybe the way of using cell phones that is different from the way the middle class uses it. But in this is a use and a consumption, and as well it should be comprehended and understood so we can dialogue with it. Within this proposal, I believe I'll also mention a work from Carolina Daltoe from geography, strengthening or reinforcing what was mentioned by Gabriela, the interdisciplinary aspect that to work with this universe, this space in which all human action is contained. Within this human space, this takes place, and we have to understand it. And within this new spaces, what is popular, the definition of popular, and its difference, and how we're going to include and how we're going to organize the the facing of the social issue that is not contained in nutrition, but it's contained in the organization. And all of this is connected with primary healthcare. And it's within this space where we have more educational space, we have more time to talk, and we have more resources to seed, to sow the seeds. Questions. Questions are always better than answers for us to work. Popular education and primary healthcare, it's always better to ask a question because the answer will come afterwards after we think what we need to know. And we need to know a lot of stuff for us to to advance. And I propose two questions here in this presentation. One, which is how can we improve feeding conditions respecting aspirations and desires, considering the limitations and social impact? And people who are watching, how do we respect and change at the same time? How do we deal with a population that is resource stricken, that has difficulty in getting access to food, to be together, because cohesion is important for primary health care? And how do we cause or how do we make an impact that is not restricted to our limits? Because we have to start just little, but this is a national seminar, and we also have to think about where we are getting in SUS as a universal aspect. It's not just the people who are close to us. That is a question that we have to consider. And it's not that we have an obligation to find an answer. You can be okay with the question, but and the other question is how do we understand through different things and everyday aspects what we should change and what we should leave as it is? So there are things that it's better not to change, and there are things that we have to find the strength to change, and because we have to, it's necessary. So that is something important to consider when we try to understand other social groups and these crossroads, and to try and find a way that is possible to build it together. Let's move on to the next slide. We're getting close to the end. Proposals. Proposals of popular education that will develop skills. The possibility to think about information and nutrition. Have you seen the hot dog with banana? I had never seen, I mean, did you see it to the picture? Yes, but I had never seen it prior to that. But assessing these questions and to assess this information in the universe of primary health care that is not just restricted to nutrition and food, but it's really important in there's nutrition in food. There might be a huge volume of information that will be an obstacle, will be a problem. So that is an issue that we have to consider. We have to develop of understanding and to dealing with information, collaboration, social cohesion that was mentioned by Marina as well. That's why the team effort or teamwork is important. Just wanted to make sure that we can include the social medias in this respect, because nowadays, in this world that we live, we have a culture of the internet and the cell phone, not only the internet, that is necessary to understand so that we know what kind of support we have, building new alternatives that have to deal with this, and alternatives have to do with the fact that we are giving up the model, we're not sticking with the model, but we love being together, but sometimes we do need remote learning, we do need to use cell phone for people who are not within the network, we can make new friends, we can get some knowledge, bring things from other countries. And so these are alternatives that we have that will force us to work remotely. Also, the protection of the environment. In this environment, here is the conception or the meaning of Milton Santos. It's not just this jungle or something. It's the human space. We have the indigenous and the forest that is living in interaction with it. So this environment is a living environment. It has to survive, and you cannot just squash one part and disconsidering, dismissing one part. These agents have to be fluid in this kind of the education that we're proposing, which is the popular education. So that is a skill that we have to develop because it's not easy at all to do this. So problem resolution, technical problem resolution, I believe that it's fundamental for us to be clear that political advocacy is one aspect. We have to be connected to political fights, and there are technical issues that are connected to the specific and technical aspects and the people who are planning they are sowing the seeds, and that these are different aspects. So we have to develop this ability, and population has an idea. Okay, has creativity that is fantastic. Can you go back a bit? And the last aspect that I'm going to mention here before I finish, I'm getting close to the end here. So technique has to be with ability and the condition to improve when we're there. So everyone has technical capacity, everyone has skills, and I don't believe there is a human being without skills. When we talk about the human aspect of the SUS and primary healthcare, we cannot there shouldn't be a group or a person that is deprived of the conditions. The conditions have to be provided for them. And we that are healthcare professionals, we need academic resources, reading resources and tools, governmental funding. We're going to have to use these tools that are available for us in public policies for us to think what we're going to do in that place. We cannot just leave people to their fate. This is not a problem. This is a challenge that we have to overcome because things are they're kind of hard. We cannot just face it. We have to deal with the information.
E dentro desse universo, eu volto com a.
What is urgent? Because going back to José de Castro, if we have this difficulty here with nutrition, and the way it is, because we're going we're going to get rid from reality.
Então, no conhecimento do chão com uma boa base.
And that provides us a basis. Even if we have a layer that is more middle, intermediate, or a more intellectual layer, we should have be grounded in this respect. And a person within that subject or culture, it's a person that interacts with the culture. So this is the person that should be responsible to answer and respond. This is what we should consider as popular education. In reality, it's more education than a popular education, the perspective, because it is this exchange of different points of view and ethical possibilities of having everyone in that group of getting advantages and getting something out of it. And within the possibilities of conducing the good, what's good, what are the possibilities that we have there? Nobody should be left out. Nobody can be left out, because if someone is left out, there is something wrong. There is something that is not SUS, because SUS is for everyone. And the last aspect, something very useful. Sometimes we don't ask the population to be involved and the concept of citizenship. And we are sometimes really pressed to provide food and to provide healthcare treatment. But I think we have to provide both things at the same time, because if the person thinks it belongs to this place and to this system, this gives or provides better conditions for that person to negotiate and say what is going to be a solution for those problems. I'm going to provide an example here as the last part. There was the integrated system in the Federal University of Rio de Janeiro, where we had a lot of works and papers. And this doctoral thesis student was said that in her last work, she saw that the consumption of non-sugary drinks increased, and that I find that it's really interesting because we also always think about the consumption of sugar and sweeteners, and the person that doesn't include sweet, and if you have given up, if you just said, I'm not going to use sugar anymore, we forget about it. I want to end on this note. You can go to the next slide. Thank you very much. To thank all the students and everyone who's connected to the lab that I coordinate, because everything that I'm saying here is a consequence of the studies that were carried out by this group, the people who weren't able, who had problems, the people who managed to go there and couldn't go there, and this result. And in the end, it's the Federal University of Rio that is, and the institute that is producing this. So I'd like to thank you, thank everyone for the possibility to make my work and show my work, because that's what I'm paid for, to show everything that I managed to develop so far. Thank you very much. Goodbye.
Thank you, Professor Maria Cláudia. Professor will brought this look for human right, about the social possibilities, and to be able to communicate and to reflect about this popular education. And then I think that we can highlight in her speech that popular education and the possibility to think about the differences and how do we include these differences and how do we dialogue with them, with these differences. And I think that an important element that she brings, which is also in our guide for the population, Brazilian population, is the importance to think about culture and take it to be a part of our work. And for us to think about precisely how people are living and how they understand the world and how do we incorporate this in our work as health professionals and workers from SUS. Now, I thank Professor Maria Cláudia Carvalho, and we are now, I receive here the notice that I think 2 lectures were very praised in the chat, so we thank again Professor Marina and Professor Maria Cláudia. And we remember that the chat is also open for the issues, the comments, that you would like to put for our lecturers. And now we are going to begin the moment for debates with the representatives from the social control. To begin this, we're going to invite Dr. Miriam Coelho, representing the National Council of Health, to help us to reflect on how to incorporate or improve the issues of care in food and nutrition to form the different health categories for an action that is interprofessional in the primary health care of SUS, contemplating popular education. You have 10 minutes for your comments, and when there's 5 minutes left, we are going to tell you. Thank you very much and welcome. Well, thank you. Good afternoon to you all. I am very baffled by the presentations that happened before, and I'm very thankful for being here. Certainly, I will listen again to everything that was said at this moment. Well, I was invited as a representative for the National Council of Health, and well, I would, and this is from this place that we are talking from. I think that we when we're talking about the education and how to incorporate the issues of food and nutrition in the education from the many categories, professional categories, I think that this is a challenge for us all to recognizing that when you talk about the professional education, we are talking about these spaces for to defend the what the category wants. And so how we're going to negotiate these issues without with tranquility and understanding that we are abdicating from what it would be our attributions, but contrary, we are it's among our attributions to improve the conditions of food and nutrition for the population. So I believe that this is a great challenge and that we need, I say, as nutritionists, all the time, we need to ponder, even because of the presentations that happened before us, to understand the necessities, because there are many, the possibilities are also many, and we need to advance in this construction. And then I would like to bring here a contribution that I believe that not all of you know about, that the Constitution, the federal Constitution in the 200th article, puts that between the competences from SUS is the ordinance to form human resources in the area of health. So the education in the area of health is not something that can be from the outside. It's not an attribute that's from the education. It is from education, but that goes and demands, according to what was said in the Constitution, of an appropriation from the health sector about this study. And then on Tuesday, talking about the law 8080, we talked about the intersectorial commissions, which are subordinated to the National Council of Health, that have the end to articulate the programs, the interest for health. And then one of these commissions, it is the intersectorial commissions of human resources and work relations. This commission articulates the policies and programs in the perspective to integrate teaching services, management, and community beyond formulating the guidelines for the management of work in healthcare education, be it in the technical level, postgrad, undergrad. So in practice, this commission will be appear there in this reconnaissance and renewal of undergrad courses in the healthcare area, thinking about the social necessities of health. This commission is composed by representatives from associations, teaching associations, federal councils, professional federations, executives, student executives in the healthcare area, managers from the Ministry of Health, Education, workers, counselors, and this commission has also a technical chamber that deals specifically with the themes connected to studies. It is this technical chamber that is discussing the proposal to reformulate the guidelines related to the nutrition course, our DCNs. ASSIST is based in one resolution from the National Council of Health, which declares, firstly, as a basis that in order to homologate the opening of courses through the Ministry of Education, that it's necessary to have only a non-objection of the Ministry of Health and the National Council of Health, that the emission of technical criteria, educational and sanitary criteria related to the opening and reconnaissance of courses that go through the regulation from the state in the same way that the National Council of Health reaffirms that health is not a market, education does not also be. It reinforces the necessity to democratize the superior education, the necessity to form professionals with a profile, number, and a great distribution adequate to SUS, and the necessity to establish projects, political and projects which are compatible with the proposal and curricular directories. So some criteria are considered through this resolution. Other social necessities, the demonstration of the social compromise of the course with the promotion of the development, regional development, through facing the concerns from the population, health concerns of the population, the demonstration of compromises from this course with an offer of residencies, specializations according to the necessities, healthcare necessities, and the unified health system, the demonstration of the compromise of this course with the production of knowledge for the necessities of the population and for the technical development of the region, to demonstrate mechanisms that reinforce the interiorization fixation of professionals, including the compromise with permanent education of the councils and the professionals for healthcare services in coherence with the construction of SUS. And then we talk about some of issues that were put before, especially that the professional, nutritional professional, it is a luxury in the interior, and we are now going to debate about this respective, and at the same time that we recognize the necessity to be concerned with the places that where we have the studying of the professional that is more concentrated in the spaces in Brazil. The project, the pedagogical politician, which to be coherent with the necessities from social necessities through the innovation of proposals, pedagogical proposals oriented by the guidelines, curricular guidelines, or the explicitation of the practice sceneries and the compromise with integrality to multi-professionality and the production of knowledge that is socially relevant. The organization of curriculums with the curriculum within the perspective of the formation of the healthcare teams with education practices through active methods and permanent education. From the organization of curriculums and learning practices oriented by the acceptance of a diversity of gender, ethnicity, social class, and creating the necessities for special needs, production and construction of partnerships about places, compromise with the promotion of knowledge about the reality of the place, the knowledges, and with the development of responsibilities between the institutions, students, and professionals. Well, compromise with the dialogue between professors, and that the courses contribute to face the inequalities in the offer of the courses. Well, I would like to then make it clear that this is a manifestation in this direction that the National Council of Health acts. In this moment, this commission is directly analyzing the courses that are not of nutrition, there to get those who have been fulfilling this attribution to evaluate the opening of the courses is the Federal Council of Dietitians. I believe that another person is going to talk about this later. Then I am available here for questions and other comments. Thank you very much. Thank you, Miriam. And now I'm going to invite Dr. President from the Council of Nutritionists from CFN to share with us his comments about how to incorporate or improve the issues from care and food and nutrition for the education of the many categories of health for an interprofessional acting in the primary healthcare at SUS, contemplating popular education. So it's Dr. Elido Bonomo. You have 10 minutes, and then there's only 5 minutes left. People are going to tell him. So welcome. Thank you for the invitation. CFN thanks, and we celebrate the organization of this important event, this international seminar, a debate that is very fundamental in a moment in which we have an extraordinary number, a world and a number of people with food insecurity, to bring this theme of food and nutrition through the education, professional practice, look into the society as a way to care, and a thing that is very central to promote and recover health the, to the best part of the population, the most part of the population, especially in primary healthcare. Since a lot of people have already talked about a lot of things, they're very fundamented. I'm going to now talk about the role of CFN in the education, professional education, what we're talking about. So the Federal Council of Dietitians, it orients the professional acting of dietitians. It is a perspective for that. It is a right for humans to have a good quality of food and having the safety. And for that, we need to do some movements, which are political and legal and technical and administrative ones within this system. They have advanced in the defense of the adequate food nutrition to what is referred to the local culture, due to a social and environmentally sustainable project. So we have been provoking this with our category, with our coordination of courses, reflects a procedure of humanization and care in this area, and an attention that respects the many issues, what we're putting now, that goes beyond the biological component. See that the discussion from interprofessionality is fundamental in primary healthcare, in its formation in primary healthcare, but for such, it is necessary to have two other components: that you have a multi-professional team, the respect in the form, the studies and the references that are put there, and also that there is a public policy that put this in the center of the issue. I'm going to say here about two important participations that the Federal Council had alongside other organizations from the society and governmental associations, which was the partnership and participation in the Mark for Food and Nutritional Education for public policies in 2012, how this was incorporated in the policies in practice in the day-to-day basis of the basic care. And in another moment, the Ministry of Social Development previously with CFN, with the Federal University of Ouro Preto, elaborated strategies to sensibilize and publish booklets for nutritional and food education, which was distributed to many secretariats, municipal, state ones throughout the country. This document, built to many organizations and with a lot of people and many hands, needs to be appropriated for the healthcare workers as a methodological practice and conceptual in its day-to-day basis. So we want to know if this was done. For that, there is a necessity of policies that provoke this. I'm going to say later documents that we spent a few years discussing, thinking about the study and what was being discussed. The new ethical code of conduct approved in 2018 brings at least two articles that I would like to state to you. The sixth one, the dietitian needs to perform his attributions respecting life, the singularity of the patient, the dimensions and religions, well, the corporeal and religions of the patients, race, religion, the diversity of the practices, food practices in the dialogical way, without discrimination in each professional relationships. And the sixth one, emotional attention given by the addition needs to go beyond the biological significance and consider its environmental, cultural, economical, political, psychoaffective, and social and symbolic perspectives. So they are movements within the system that we have been working in this perspective. This 600 resolution from April 2018 recognizes different fields in the practice of primary healthcare attention from an experience of life from the professionals within this system that normatize this practice, making it concrete, establishing the main attributions in these acting areas. The Day of the Dietitian in 2020 talked about nutrition, citizenship, respect. So I'm putting to you some movements formal and informal, technical and scientific ones, provoking a discussion about the care in technical assistance from citizenship, with a highlight to the theme sexuality. And we had this movement also dealing with issue as a relevant for our formation and also the professional exercise. Recently, in 2021, there was a resolution that regulates the notion of integrative practices and complementarians in health by the nutritionists. It already exists, other professionals do it, but bring it to inside an alignment with the national policy of with the integrative practices, so provoking our category of education with a permanent dialogue with the coordinators, course coordinators of graduation and nutrition in the country so that they can incorporate it in their pedagogical projects. So we have different actions and coordinators. Since we have many courses in the country and recently a proliferation of courses, distance course, online courses, the education is distant a little bit from what we were hoping, what we are debating and putting in our norms. As Midian said, we have within the Council of Nutrition is what we call the Commission of Evaluators of the course, which are researchers, professors who have an experience in the coordination of courses, which help us in a voluntary way. However, the decision for the Evaluators Committee do not obligate the federal government, the Ministry of Education, to agree with what we say. So what we have been seeing and hearing from our evaluators is that it's an important part of this debate that we are doing now, that it is not does not arrive in the pedagogical procedures because it's very severe, because the construction of these courses foreseen in the directories of guidelines for dietitians, its construction should have the participation in the municipal SUS, in the management, in the municipal public policy, contributing to see how this professional is being considered within its components, its studies, a regard to the unified health system, and then a regard to the activity, interprofessional activity, interdisciplinary activities in primary healthcare. We have a provision of meetings every 2 years of professional studies with coordinators, course coordinators. We have been insisting of the necessity to understand the interprofessional work. However, our governance with the organization of courses, it is very fragile. So it still exists. We participate in a qualitative way with the work, hard work, and we following up this to the perspective, to the regard of the Federal Council, but those who define is the federal government, the Ministry of Education, who authorizes or not this. And in Brazil, there are people from outside Brazil. Brazil, it is the system, educational system. In its majority, we almost have 40% of our students in nutrition to have go to the private initiative. Of course, we have private companies for education, which is very qualified, but in other parts of have an influence, political one, of other people who are for senators, ministers, and then their decisions, they are not only technical ones. They are not for only for the components that should be discussed. So the Federal Council gets in this sphere to orient, to forward, and suggest and denounce in certain cases. We do not authorize something. So most of the cases, we do not authorize the recognition or the functioning of courses, but here is not a final word. So the evaluation is a decision that is done for the federal government. That's why these components we have been provoking. We think that the professional advances, mainly with the resolution 600 in the Federal Council of Nutritionists of 2018, it amplifies its acting areas, giving a way for the public policies and for primary healthcare. However, we have a limit in our action to be able to act. And then I repeat myself about the necessity that when we incorporate the issue of food and nutrition in their education to basic healthcare, but we also need a multi-professional team, professionals that are not centered with an action that is in one or another specific professional, and that we also have public policies that would give a north to this multi-professional action so that we can meet to have a more care to the population's health that depends in a quality service and needs multiple healthcare. Thank you very much.
Muito obrigada, doutora Elidan.
Thank you, Dr. Elido. You gave an important speech for us to enrich this debate. And now we arrive in the moments to exchange and interact between the public and the panelists, debaters. We thank the participation from those who are in the chat because we believe that the advance is only possible when we can exercise our necessity to have a dialogue with like the table has been saying in these times that we are here together. So the team gathered some issues that were brought here, some questions, and then I'm going to say them. So first for Professor Marina Peduzzi, the question that arose was, what is still necessary to strengthen the work, multidisciplinary work and interprofessional work in primary healthcare? And then, taking the lead, there's also a question for Professor Maria Claudia, which is how professionals, healthcare professionals from the primary healthcare can approximate themselves from the culture, for the popular knowledge, this constructing this biomedical view and decentering from what it is now. So we thank for these questions. Well, thank you for the question. I think that I can begin, or maybe Claudia. I will try to answer here very fast. Thank you for the question, and thank you for the opportunity to be here in this table and hearing what my other friends here have said, and to say how it is complex this, how do we need to look, like, to give it this round here about the discussion. We need to look for many angles, or else we're not going to see anything. So I think that there were many advancements. It is recognized in the entire world that the primary healthcare, it is a field that has most advanced in this field alongside mental health. It has also a great tradition of work, a teamwork, but a professional work. I think that mental health care and primary health care, and both because they leave, let's say, this biomedical model, they escape this model. Primary health care, it's an entrance, it's closer to the groups, to the families, the territory. And that's why it's necessary to look from the optics from integrality. So when we look, all professionals, when we look for primary healthcare, we look like this. We need to notice the people's lives, families' lives, different from when we arrive in a hospital, in which we hope that they look to us with this small look. Look, I need to solve this thing fast. Of course, that we are always a person that has a family, that has a historic, a life. And integral work is present in all this health system, but in the primary healthcare, it is fundamental. You cannot think about primary healthcare without this integrality optics and the universality optics. And from the social participation, because primary healthcare is there, open for families, for people, and we advanced a lot in Brazil, SUS, with these strategies, special strategies, the introduction of the strategy from the program Saúde da Família, and then which was strengthening itself and being recognized as a strategy. This is recognized in the world. There is an international recognition from the quality, effectiveness, and excellency of our model. So We advanced a lot the approach in team approach, interprofessional approach of the many optics. It advanced a lot, but in the last years, we need to recognize that there has been some challenges, and there are many challenges in the head. And then I think that since the question is how to strengthen it more, I think that the path, the unified health system, these strategies, this approach, team approach, and multi-professional approach, interdisciplinary, I think that this is the path. The tendency is this one. However, the issue is that we have challenges that are presented, challenges that are being put there. So, for example, that from people are saying from the policy for basic care that each team for strategy can have one community agent, only one, or the healthcare teams cannot have community agent. This is something that, oh, it is a detail, just as there's just something, but it's something that compromises the community agents in the perspective of strategies. Thinking about it as an excellency model for primary healthcare, of course, there are openings. It's not that SUS and primary healthcare resolved everything. This is not what I'm talking about. There are many openings, there are many things to advance on, but much has been done and done in the perspective of work, integral work, amongst the different areas. But there are elements, critical elements being put there recently, which are very critical. We can, for example, discuss also about the reduction of the working hours of doctors that currently can reach even 10 hours per week. That is reduced to 10 hours per week. How to integrate professionals if they can be in this team only 10 hours per week? Of course, it's not a mathematical thing, but to integrate teams, it is fundamental that professionals live, let's say, that they are there acting and the connection with the population. So there are many elements which put in check, let's say, the model of interprofessionality in primary healthcare. And this does not happen only in Brazil. I think that we are saying Brazil because it has been implementing an architecture, a drawing of primary healthcare that is very interesting. So there is where this compromises the advancements that they have already reached and which can need to follow up because there's much to be done.
That's what I was telling you. We have in communication a fundamental element between professions, but it's not only communication, we also have the technical issue of the teams that have goals and monitor each other's work. For example, in an emergency, the service of emergency, the professionals should develop a culture and practice to monitor their colleague, to say, you know what, you forgot. It's fundamental for them to have this practice. It's very important for them to monitor each other. It's not like they're controlling. They're just supervising. Because sometimes we don't pay attention to something, and to have the culture of integration and to say to our colleague, you know what, I think this aspect here, this thing you forgot, and then to solve the problem of the patient. And our fundamental issue in this work is what do the users and patients and the population in this place need? This should be our question. It's not what the profession does and nursing. Of course, it's important what nutrition does, nursing as well, but the fundamental question is, what does the user and the population need? And in order to do that, we have to monitor each other. We have to help each other and in each other's works because sometimes some things just go unnoticed. So I'm trying to answer very quickly. But highlighting this aspect, we have moved forward a lot, we have progressed, but a few things and changes that have to be suggested, they have to be implemented, that they might threaten the interprofessional work. Thank you. Thank you, Dr. Marina. Now, Professor Maria Cláudia, please. Can you hear me? All right, then.
Tá me ouvindo?
Sim.
Yes. Can you hear?
Pode seguir. Tá dando para
Okay.
escutar.
Go
Tá.
ahead, we can hear you.
Ficar instável aqui para mim está dando tudo certo. Então,
Uh-huh.
essa questão do saber
So
popular,
the
e
popular
do saber
knowledge
biomédico, é uma
and
questão
biomedical
também, assim, que nem
knowledge
Marina
is
falou,
an
uma
issue
questão que
that
acho que
was
você
mentioned
colocou
by
aí para nós, não
Marina
é nova.
as
A
it's
gente
something
tem
that
uma
is not new,
formação
right?
que
We
ela
do have an
tem
education
essa
that
resistência. Mas é porque é
has
difícil
this
mesmo, não
resistance,
é
but
muito
it's pretty
fácil. Eu
hard,
concordo
it's
contigo,
not
eu
easy.
também acho que a gente está
And
avançando. Mas a
we're
minha
we're
resposta
evolving this
seria
aspect, but
conhecimento,
my
na
answer
verdade.
is
Eu acho
knowledge,
que
right?
só o conhecimento não
Knowledge
traz o
alone
conhecimento. Só o
replaces
conhecimento avança
knowledge.
no conhecimento.
Only knowledge moves for knowledge forward. There is a philosopher that says that
Substitui uma paixão
we
por outra,
only replace a
né? E
passion
se
for
você
another
pegou
one.
essa
And I
agonia,
do
essa
follow this line
situação,
of
por exemplo,
thought.
de uma
We
coisa,
don't like
a
eating,
gente
if we
gosta
don't like eating
daquilo,
something,
né?
we don't just
A gente
stop
gosta de
liking
uma
it.
coisa, e aí a gente
We like something else, and the other one
o
gets
que
a
que a
bit
gente vai fazer?
old, and
Então, eu
we
acho que o
remember it.
conhecimento
But
também é assim,
I
nesse
believe that
sentido, para
knowledge is the
falar. Eu
same,
queria dizer que não é
works in the
somente o
same way.
conhecimento
I'm a bit
acadêmico, né?
suspicious in
Eu estou
saying
falando
this,
do
but it's not
conhecimento
only
que a
about
gente já
academic
trocou
knowledge, it's
aqui,
the knowledge
né?
that we're
Nessa
exchanging
mesa,
here
nessa discussão, nesse
in this
seminário,
panel
ou na conversa
discussion, in this
toda, que é
seminar.
quando
These are
analisamos o
proposals that
documento, que
update
ampliam, que a
knowledge,
gente vê
that
que tem muita
broaden
gente que
knowledge, and we
pensa
see that a
como,
lot
como
of
a gente,
people
que gosta
think
de
like
trabalhar na
us.
educação
They like
popular, que
working
gosta
in
da nossa
popular
realidade. Isso
education. They
aí
like working in primary
seria uma forma da
education.
gente
And
conhecer
that
e
is
saber do que
something
está
for us
precisando.
to
Então,
know,
eu
to
acho que
learn,
a
to
resposta é o
help
conhecimento,
each
no
other,
sentido do
support each other.
conhecimento.
The
E
answer
aí,
of
finalizar
knowledge
um pouco,
replaces
né,
knowledge.
dizendo que
And I'd like to
essa
go on by
perspectiva que eu estou
saying
trazendo
that
nessa
in the
apresentação,
perspective
que
that
é
I'm
das
working in
ciências
this
humanas,
presentation that has to
então,
do with
seja
more of
essa
human sciences,
experiência
be it
de
thinking
de
about conscience in terms of
conatos, que é
Freud
uma
or
energia,
conatus,
como
which is an
Spinoza
energy
fala, ou então
that
uma forma
Spinoza
mais energética,
mentions,
como a
or
Marina
an
mencionava,
energetic
né?
with the
Como
form that
essa
is more
medicina que
used
trabalha
and
com
many other types of
essas
medicines that
formas
work
energéticas e
with
tal,
these energetic
esse
forms,
estado de cair a
energy
ficha,
forms. So
uma
the idea
epifania,
of
é
having
um
an
contato direto
epiphany,
com a gente mesmo,
that's a
né? É a
contact
gente vai
of us
aprendendo
with
alguma
ourselves.
coisa
So
na
we learn
gente,
something.
vai
We something
aprendendo
within
e
us
a gente não sabe
learns,
direito porque a gente
and
não consegue dar
we don't
conta
know
de
exactly what it
tudo
is because we
inteiramente.
cannot
Mas eu
consider
acho que
all
esse
of the human
ano é
aspects,
às
but
vezes um
the
encontro muito
human aspect only is becomes essential,
essa outra
becomes real
pessoa
when we
que você
meet other people, when
consegue
we talk to
ampliar,
other
seja
people, and it's by
profissionalmente, né?
talking to other
E eu
people
acho que
and because
esse
that we get
encontro
this.
precisa
And I
passar
believe that
por
this
um ponto
meet,
de
we have to be
fortalecimento, né?
there. That's
Às
why
vezes, se
you
você
need this
considerar, se você
knowledge.
tiver só com a
Because if
política
you're not
pública na
there, if you
cabeça,
just
como a
have
gente
public
vai
policies in your
conversando,
mind, if you
você
don't
vai
have it in
conseguir
your
falar, mas
heart,
você não vai
you won't be
conseguir
able
ter a
to
criatividade
talk.
mais
You won't
humana
be
que
able
você
to
talvez
have
desenvolva
creativity
naquele momento.
that in which which is going to help help you develop something. You don't have to just forget
De alguma forma,
everything,
as
but
duas
in
coisas
a
estão
way, these two things have to be
necessariamente
connected
ligadas.
in
Então,
this this
esse outro
person.
não é necessariamente a
The other
pessoa,
person, it's
mas
not
é uma forma
necessarily a
humana
person.
que às vezes tem que
We
ter.
have evolved a
E essa
lot in terms of
proposta dos recursos
territories
humanos,
and in the
falando do
proposal
Milton
of human
Santos,
sciences
da
of
Carol
Milton Santos, for
Daltoé, que fez
example,
esse trabalho,
Carol
e
Daltoé
outros
as
que
well,
continuam
that
adiante,
carried
que
out
estão
this
fazendo
work, and
isso.
other students
O
that are
outro não
also
é
doing the same
necessariamente uma
work.
pessoa.
The other
Às
is not
vezes, a
another
gente
person necessarily.
separa
Maybe
e
it's a
é
social
humano,
agent
mas
that
é
is not, it might not be
humano. Às
human,
vezes é
but
você
is
também,
produced by a human.
às vezes é
Sometimes
você
it's a
que mora, você
media,
vai entender da
sometimes it's a
pessoa, você vai
territory,
entender da
and
pessoa e
you
você vai
understand the
conseguir
territory as
chegar.
you understand it
É o seu
yourself. If you can see the territory,
coração, o seu
it's
saber.
your
E essa, na
mind,
verdade,
it's
quem
your
você
head and your
é
heart.
você.
So
Se
the
você
person
não tem
who's
contato
looking,
com
it's you.
essa
If you don't have
sensibilidade que a
contact with
gente
the
já está falando,
sensibility, if you're
você tem
just
menos
reason,
recurso humano para entender
you
o
have
território.
one
Mas
less
você vai
resource or
entender.
tool to
Mas
understand the
você tem menos
territory.
recurso.
But it doesn't mean that you won't get it,
Então,
but
nossa
it's one less
capacidade de
tool.
estar
And it's the knowledge and
experimentando,
our
nos
capacity to be
conhecendo
in life and
mais
experiencing and
profundamente,
know each
mais das
other
outras pessoas
and
que
know
precisam de
yourself
ajuda,
and
vai
considering other
fazer a
people that need
gente
the help.
avançar e
This
deixar o
is what is
conhecimento
going to take
biomédico
us
no lugar.
forward
Ele vai
and
avançar,
to place the
mas a gente vai
biomedical knowledge
avançar,
in a place that it's
né?
going to help,
Então, eu
but it's
acho que
not
essa
going to be
seria a
the only
resposta,
resource.
dentro da minha
So that
prática,
is my
e eu
answer
acho
within my
que
practice
vai mais
that
assim ao encontro dessa
is
questão
going to that is
do
connected to this
conhecimento.
issue
Mas esse
of knowledge itself, but this knowledge that's broader. It's knowledge that has to do with sensibility.
Muito obrigada, professora.
Thank you very much, professors. In our talks, your intervention, you highlight the need to recognize how much we have worked, and what Professor Marina had mentioned in SEGAN, in the cycle of debates about PNUD and analyzing the trajectory of PNUD. We talked about the importance of recognizing these advances, but also the importance of dealing with the challenges that are still there. And Professor Maria Claudia also mentions the importance of the different kinds of knowledge for us to know, to incorporate in our work, the different kinds of knowledge, and to value what is symbolic, what the other person brings to the table. And that's the importance of the meeting. I believe that's a very nice word that we have to keep in mind. So I thank you very much for your very enriching debate this afternoon. I thank everyone that is here that provided us this opportunity to hear and share these ideas when it comes to interprofessional education, as well as professional education in the realm of nutrition, and on behalf of the national coordination of the Ministry of Healthcare. I would like to once again to thank the presence of everyone. As it was made yesterday, our second panel is going to bring national and international experiences that will be shared. But before that, we're going to have a 10-minute break. See you soon.
Os benefícios de ter uma vida fisicamente ativa são diversos, desde benefícios de uma perspectiva biológica, com a redução do risco de doenças crônicas não transmissíveis, como diabetes, hipertensão arterial, doenças cardiovasculares e algumas formas de câncer, mas também benefícios sociais e, por exemplo, relacionados à saúde mental. Quando nós pensamos nos diferentes tipos de atividade física, costumamos definir os domínios da atividade física em 4, que são a atividade física no tempo livre de lazer, a atividade física nos deslocamentos diários, a atividade física laboral no momento do trabalho ou do estudo e, por fim, as atividades físicas domésticas. Muitas possibilidades são possíveis no dia a dia para a prática de atividade física, desde dançar, caminhar, subir escadas, descer escadas, carregar sacolas do mercado. Ao invés de você usar um transporte como carro motorizado passivo, você ir caminhando até o seu local de trabalho. Atividades domésticas como a limpeza da casa.
É fundamental que o poder público contribua para garantir a prática de atividade física como um direito. E essa prática individual ela vai se tornar mais coletiva. E aí é importante, nessa gestão, que o poder público construa leis normativas que vão dar a possibilidade da realização dessas práticas de forma ampla e coletiva.
O Programa Academia Carioca é um conceito ampliado de promoção de atividade física nos territórios. Ele foi implantado em 2009 pela Secretaria Municipal de Saúde do Rio de Janeiro. Ele visa desenvolver toda e qualquer prática de atividade física com o objetivo de melhorar as condições de saúde, principalmente promover a saúde e prevenir as doenças e as complicações associadas a ela. Ele está inserido dentro das unidades de saúde, as clínicas da família e os centros municipais de saúde e, portanto, é um serviço de saúde pública. Ele facilita o acesso da população, principalmente as pessoas que mais precisam, que são as pessoas com doenças crônicas e também as pessoas que têm fatores de risco, que são modificáveis, como obesidade.
Ter um programa de atividades físicas, com espaços, com materiais, com profissionais capacitados para estar realizando essas atividades, faz todo o diferencial. Uma coisa é um médico chegar e falar, você precisa fazer atividade física. E aí, aonde vai ser ofertado? Você tendo um espaço dentro de uma unidade de saúde, faz todo o diferencial. Porque você tem o espaço, você tem os aparelhos, você tem os profissionais, você tem os materiais. A gente também tem outros tipos de atividades. Eles fazem circuito, o grupo de caminhada, dança, a gente tem o yoga. Então ele tem uma gama de atividades que vão ser ofertadas para ele e ele vai ver a que mais se enquadra.
Eu pesava 115 quilos, sofri de depressão, comia muita besteira. Eu moro numa subidinha bem altinha, né? Eu parava 5 vezes para respirar. Foi o projeto da academia e pronto, eu entrei e foi o que me incentivou eu perder peso. Eu olhava no espelho, eu via eu assim, não era eu, até que eu perdi 35 quilos. Mudou, que eu fiquei mais disposta. Fora as dores também que me davam, não tinha disposição para fazer nada.
Muitos chegam aqui tristes por não conseguir fazer as atividades da vida diária. A gente conversa, a gente orienta, a gente tem um suporte psicológico dentro da unidade também, a gente trabalha em conjunto. Um aluno fortalece o outro, os próprios profissionais da unidade se fortalecem. Com isso, os alunos, eles melhoram a qualidade de vida, a autoestima deles melhoram e eles incentivam outras pessoas a estar praticando atividades, né?
O programa Academia Carioca, ele é muito além da atividade física e tem como resultado, né, uma contribuição para que a população tenha hábito de vida mais saudável.
Saúde Brasil apresenta 5 dicas para se alimentar melhor. Sabia que dá para fazer refeições muito saborosas e saudáveis? A seguir, 5 dicas simples para você se alimentar melhor. Dica 1. Coloque mais frutas, verduras, legumes, feijão e arroz na sua rotina. Existe uma grande variedade para escolher. Dica 2. Na hora de cozinhar e temperar, use uma quantidade menor de óleo, gordura, sal e açúcar. Dica 3. Evite o consumo de alimentos ultraprocessados. Eles são ricos em açúcar, sal, gordura e aditivos químicos e não fornecem uma nutrição adequada. Dica 4. Tente cozinhar mais. Envolva toda a família no preparo das refeições e faça da hora de comer um momento de convivência e lazer. Dica 5. Planeje a compra dos alimentos. Defina o seu cardápio semanal e faça suas compras em mercados e feiras. Isso ajuda a incluir alimentos mais saudáveis no seu dia a dia. É possível desfrutar do prazer de comer bem. Até a próxima! Quer mais dicas? Acesse o site do Saúde Brasil.
Prevenir a obesidade infantil é uma aventura para crianças,
pais
e responsáveis também.
São 3 passos. 1. Alimentação saudável. Estimule a criançada a participar da escolha dos alimentos e do preparo das refeições.
2. Atividade física. Jogue junto, brinque, pule, corra.
3. Mais brincadeiras e atividades ao ar livre. Fazem bem para o corpo e a mente.
Vamos prevenir a obesidade infantil. 1, 2, 3 e já!
Ministério da Saúde, Governo Federal, Pátria Amada Brasil.
Como diziam os tupis, o abatiu ao pé, um milho d'água, colhido nos alagados, próximos ao litoral, muito antes de conhecerem os portugueses. Hoje, o nosso arroz. E para que ele chegue na nossa mesa, é preciso respeitar o tempo. O tempo de plantar, de crescer, de colher. Ver a vida crescer a olho nu. Sem pular etapas, sem querer brigar contra o calendário, mas sem perder a hora certa de agir. É sobre respeitar as etapas do processo e também quem faz parte dele. Quem coloca força, suor e, claro, paciência. Um ciclo que leva mais de 100 dias. Depois de tudo isso, chegou a hora. A hora do Pedro colher para levar para o José organizar para a secagem. E só depois de beneficiado e embalado, o Marcos pode colocar no caminhão, percorrendo quilômetros, cruzando cidades e chegando até você. Já pensou nesse caminho? Já parou para pensar como o arroz chegou até o nosso prato? Eu sei, parece simples, parece óbvio, parece que ele sempre esteve ali, na feira, no mercado, na geladeira. Mas calma, é uma questão de tempo. Tempo de plantar, de crescer, de colher, de chegar até você. E depois de todo esse caminho, de todas essas mãos, é o momento de temperar, deixar do jeito que a família inteira adora, seja acompanhando uma maniçoba ou um pato no Tucupi, no Pará, um baião de dois no Ceará, um arroz de cuchá no Maranhão, um arroz doce de sobremesa ou, no nosso clássico, arroz com feijão de todo dia. É a hora da alegria compartilhada, da comida de verdade.
Sejam todas e todos muito bem-vindas e bem-vindos de volta.
Welcome back. We're going to follow with the presentation, and we're going to start the international and national experiences concerning action, challenges, and perspectives of the nutrition and food policies with emphasis on primary healthcare. And the first experience is in Spain from Andalusia, and dealing with the strategies for a promotion of healthy nutrition and primary healthcare. In order to do that, we asked Dr. Pablo de la Cruz, a nurse licensed in psychotherapy and in promotion of nutrition. Currently, Pablo coordinates the Andalus plan of healthcare and dealing with the Andalus healthcare promotion and the Ministry of Healthcare of the program of the regional Ministry of Healthcare, and Dr. Montserrat Roman Cerejo, and doctor of the University of Malaga, specialist in promotion of the sanitary context and social context by the University of Granada. Mr. Pablo, and you have 30 minutes for the presentation, and when 5 minutes are left, we will let you know. Thank you for your presence.
Buenas tardes. Muchas gracias a la organización por invitarnos a participar en este seminario internacional. La verdad que es un verdadero orgullo para nosotros poder participar aquí y poder mostrar nuestra experiencia de Andalucía, ¿no? Una región al sur de España. La presentación, como ha dicho la compañera, la realizamos a media entre mi compañera Montserrat.
And my colleague Montserrat. And we're going to deal with strategies of promotion of health, promotion of primary health care, in this case, dealing with the autonomous community of Andalusia. I'm going to talk about what is the strategic framework of the promotion of a healthy life in Andalusia. And after that, we're going to talk about a program, STEA, the program of educational and healthy habits and healthy life. And my colleague Montserrat is going to deal with more practical vision of as a nurse in a health clinic that is going to talk about healthy lifestyle in terms of primary healthcare. When we talk about the strategic mark, and the currently aspects, we're developing the new strategies of promotion of a healthy life that is represented. And this slide, such as similar to a windmill. What we want to represent here, as you can see here at the center of the windmill in the person in the cycle of life, and the perspective of gender, which is special, is at the core of the promotion of the healthy life, considering the inequalities between a man and a woman. And also the center element, we talk about whole health, which is a holistic aspect of health. And then we have the aspects of that we want to promote here and the blades of the windmill. We can see here, we talk about integral health, and it represents the whole aspects. In order for the windmill to move, we need to have very healthy nutrition for their health to improve. And if on top of that they have very good sleeping habits and they have healthy emotional habits, and it has a responsible sexuality also, their health will improve a lot, and the windmill would work faster. But in order for the wind to work, we need the four aspects that are represented here. And the first one that is represented is positive health. In this strategy, it's geared towards the well-being and in trying to prevent the problems and dealing with the treatment and recovering from health problems. And in order for this, the health system in Andalusia has a strategy. So this comes from also, we also use the assets of the community that are present in the community, in the neighborhoods and the community. Another transversal aspect or structural aspect is the equality in healthcare, the determining aspects of social determinants in the health. Very often, we develop programs of healthcare, of healthy living, but it doesn't get to a sector of the population. And sometimes it only gets to the sections where people already have a very healthy living. The third aspect that we mention here is health and local environment. If we want to get to people, we have to be close to them, the places where they live and the places where they are. At work, at school, the community, in all aspects of life. And the fourth aspect is health in all policies, present in all policies. In the seminar, we have already mentioned about that it's necessary for all sectors of administration to promote health if you want to promote this healthy living or healthy habits. It's a topic not only of sanitary authorities, but it's connected to employment and urbanism and many other aspects in society. This strategy, in a specific way, is going to generate synergies in all the programs, activities that are going to be developed in the sanitary aspect and other areas of the Andalusian administration. Here, we're going to mention very many programs in four aspects that also approach healthy eating. As you can see here in the first one, in the sanitary aspect or realm, my colleague Monse is going to talk about this to promote very healthy habits and then in the educational aspect, we have a program that it has a very strong impact in all the kids from Andalusia. I'm going to talk about it, which is the healthy living. And we incorporated the Forma Joven program that deals with teenagers. And after that, in the working environment, both in private and public companies, we approach many different habits, especially healthy nutrition. And here we have another program in local aspects that is in coordination with many other areas, where we design a plan of local network of action in healthcare, and that involves the general community and many stakeholders, and that the healthcare department supports it and assess it for the development. That is the overview of what the Andalusis programs that have to do with healthy nutrition. The second aspect, which is what is the program for innovative education and habits, before talking about this program here that is represented by this picture, I'd like to talk about where we started. Our starting point, let's get back to 2015, where we had over 10 years of collaboration, and the ministry, many other departments of sports, healthy, social services. But there wasn't a common milestone or framework for our collaboration. And even if we talked about a common framework, we didn't have a very good coordination of these programs. The protagonism up to this point, we had professionals from different departments, and we went to the educational centers to talk about this topic, to make intervention and presentation. But the school had a more passive role, more of a receptor. And the educational center incorporated these actions, but not always they were part of the educational project. Some teachers had some initiatives, and but it was not. Some projects were connected to the administration of the center, some were not. The contents that were shared, especially healthy living, the prevention of smoking, and mental health, they were approached in an independent manner, one from another. And the content, with the exception of feeding and nutrition and physical education, and there was a program that lasted over 10 years, was more centered in the prevention and in the approaching of the health problems instead of just promoting healthy habits. What were the facilitating aspects that helped set up the new program? We talked about the existence of innumerable examples of good practices in the communication, and there was a very close relationship between the professionals of education, healthcare, and social policies. We had been working for a long time. We wanted to have a more integral and more positive approach in the healthcare, allowing the integration of the different programs and to have a more broad program, and that would last for a longer time. Everybody wanted to have a more integral program, and we wanted to integrate them all in a broader one. There was also an investment in the education for a more protagonist role in the promotion of healthcare, especially in Escola Total. And for example, there was the support of the center, the active participation of students, the involvement of families through the associations of parents and of mothers and fathers, and the incorporation of the promotion of healthcare in the curriculum of the centers, the educationists, from a perspective that is transversal. So we had an activity, and the school would continue with their routine. So we wanted them to integrate them into their routine. So these activities of promotion of health should have been incorporated. So there was also the professional from healthcare and social professionals. They had to take the leadership, and they needed an active collaboration. It should continue over time. Sometimes it took some time, and sometimes in some places it didn't last, but it's hard when we're used to working in a specific manner in our comfort zone, for example. It's hard to start working a different manner. In this case, because of a problem of adaptation of healthcare professionals, they had to position in a different way. They had to take a leadership role instead of just supporting the professional and the education professionals, and they had to take the leadership. There was also they wanted to a more secure and emotional environment and equalitarian. that would pay attention to the people who were more vulnerable and had social risks. And the last aspect, aligning with the salutogenic, which is centered in the generation of health and well-being. There was an investment that were centered, there were aspects that were concerning the education, the school, and the surrounding areas as well. So these were some of the premises that allowed us to put into practice the new promotion, the program of promotion of healthy habits, and one which is Crescendo em Saúde, which is growing in health, which is in a place in primary education, and the second one for Formahoven that was in the secondary system or high schools. And this was an integral program and had 5 lines of intervention. The first one connected to the emotional education, and emotional education wasn't approached before. What was mentioned was the prevention of mental health problems. And one of the factors that were successful was that we started using the language in education, which was for us, that protected the mental health, and the mental or emotional competences were something important that had to be mentioned. After that, the healthy style of life, and then here we have physical education and healthy habits of nutrition. And the third one was self-care, and the third, another one, sexuality and equalitarian relations. That is going to change, and it's going to be approached in all of the stages and all the grades in school. The fourth aspect was the positive use of technology. That's another element in our lives. And even if there are elements of risk, here these are incorporated because we can make a positive use of this aspect. And the fifth line is the prevention of addictions, which is a line that was not integrated, and now it started being created in these strategies. The key and the core of the program, it was that every year, all the schools that were registered in the program had to develop an action plan. Every year, this action plan would be renovated, and the core element was the health promotion team. So every school that had this plan, they needed a team where many different professionals from the school and the professionals from primary healthcare also were part of this team, especially when it comes to addiction, and also the community, the educational community at large. And this time of this program, we had an initial analysis where we talk about the needs, the assets in health in the area. In this academic year, you start the topics, the specific topics that are going to take place. You know that it's a very big program, and there are many different resources and that are available for all these people. So every year, the school would establish the needs and would define, in this respect of healthy nutrition habits, we're going to approach this topic. In terms of physical education, this one here, they would decide jointly this, and after that, they would analyze how they're going to act. And then there was an assessment. So this year, this work had to be taken yearly. And the action plan would have to be renovated yearly as well and developed also. And to end this part, to talk about the current situation of this program of healthy living in 2021, we have over 2,100 centers or schools and primary schools, high schools that are part of the program Crescendo em Saúde and Growing in Health, and that involves people from kids from 4 to 12 years old. And then we had secondary schools or high schools that are part of the Formahoven, and so we have over 3,000 education centers or schools in the region of Andalusia. And that has an amazing impact, but we got to most teenagers that are present in schools. In this year, we started 2 different pilot projects. The first one, it's called Creciendo en Salud, from 0 to 3 years old, which was a project that where I was mentioning, but it wasn't developed in this area, in these age groups. We're including these age groups too. And the second pilot project that we're also developing, that we have Escuelas Promotoras de Salud, in which the schools that promote health, and they are in a way, it's incorporated in the program that we're developing. But this is a further step in the excellence of promotion of health in the educational system. So we have a pilot project of 3 years, and everything that we had mentioned before. We're talking about the transformation of this school, the structure, the dynamic, the opening to the community around it. And this project, the pilot project starts, and we're going to see how this is going to impact in the schools and in the health of the students, and trying to continue it. And now I'm going to leave space for my colleague Monse, as I mentioned before. She's going to talk about the reality from the perspective of a primary healthcare professional. Thank you very much.
Bueno, muchas gracias, Pablo. Voy a intentar compartir.
Thank you. I'm going to try and share my screen here.
Ahí. Bueno, yo voy a intentar
I'm going to try and show my experience here in clinical practice, and to tell you that. Can you share on full screen mode?
Sí, que la pantalla completa.
La pantalla completa, isso.
Perdón.
Sorry, yeah, full screen.
Creía que la estaba compartiendo.
Pero no completa.
Uy. A ver, un segundito porque... Perdonad, pero pensaba que estaba compartiendo la...
I thought I had been sharing the full screen. You have to share again, and after that you have to choose full screen.
Dale a compartir pantalla y...
A ver.
Y ahora dale a pantalla completa. Dale
¿Ahora?
Ahí. Ahora, sí.
Sí, vale, perdona. Gracias. Bueno, estaba diciendo que yo voy a intentar explicar brevemente desde...
So I'm going to try and explain very quickly my professional experience with the strategic line that was mentioned by Pablo, and how we can carry it on to clinical practice. So the first question that was asked is, how do you do with different groups with a lot of diversity? As we are talking about healthy eating, there is a list of ingredients that we can use here. I believe that it can be easier to explain it this way. Some ingredients are extremely necessary, and they are the ones that are referring to all of the programs and the primary healthcare centers. These are professionals that are dynamic and they coordinate all of the activity. And it's also important, the education and of these people, these professionals that not only teach concerning citizenship, but also that will teach other and give education to other professionals. And in terms of proactivity, we're going to explain how the action-reaction element works. And also have the network and with social services and education, the schools and neighbor associations and parents association as well. That's a way to connect all of the resources and to work in a way that together that will result in a very effective way. Naturally, Pablo was talking about the attention to the vulnerable groups, the research and guidance and results of assessment, and the continued improvement that is also a fundamental ingredient, continuing all of the assets in healthcare. I'm talking about everything: infrastructure, talents, people, and every resource and stakeholder that might be valid. And also another ingredient is to generate synergy. Other ingredients that are very important: imagination, creativity, and to analyze the motivations and the necessities and interests of citizens, because very often we have a preconceived idea that this is fantastic and it's going to be very successful, but we don't act. We have to remember that we have to be flexible. We have to be flexible because in reality, the need and the interests are not the ones that we had foreseen. And social abilities that are important: assertiveness and active listening, and clinical motivation and interview as well, and also guidance to the community, and also a lot of will and
Es lo más difícil. ¿Cuál es el punto de partida?
And what is the starting point of all of this? I'd like to say where we started before what Pablo mentioned. We had two different programs that were related to lifestyle. One program that for a children population is the integral plan of obesity, and for adults we had PAFI, which is the plan of physical education and imbalanced nutrition. So these two programs had been developed in the primary healthcare environment, and initially this was a risk population, a population of risks, and kids that were obese and had overweight as well. And the adult program, we had adults that had risk, circulatory factor risks. And these programs involved physical education and balanced nutrition, basically. They didn't include the rest of the content that Pablo referred up to that moment. And what was the methodology? The methodology was the healthcare professional, family doctor, nurses, pediatrician, and from the medical appointment, they detected that a child had some of these risk factors, and they analyzed what was the degree of motivation or level of motivation. If this person wasn't very motivated, they would be offered some advice, basic advice, to try and to ask them to have another medical appointment. And if there was enough motivation, they had the choice to be part of the Consejo Dietético Intensivo, or dietitian council, or nutrition intensive council. And it had two models, the individual and the group one. And Dr. Monserrat, you have 5 minutes. Thank you. And one model was, we had the value of the anthropometric follow-up with the kid, and the recommendations were made concerning physical education and balanced nutrition, and the duration was 6 to 8 sessions, both the individual and the group one, and which it was highlighted this content, and we try to increase the level of motivation of the person to introduce change in their lifestyle. In the group mode, there was the part that offered the benefits of group education that increases the motivation and the integration, interaction in the group. But there was also, it allowed also for the activities to be more practical aspects. And so the content were more internalized, were better internalized. But when it comes to kids, there were some limitations. First, we had to pique the interest of these kids for healthy nutrition and for physical activities as well. And comparing to remembering that they also had some other motivations like video games and other things. And we also had to involve parents. We also had to incorporate these groups of adults and the parents and the grandparents of the kids that were overweight or were obese. And we also offered extra sessions that were adapted for these kids and these boys and girls that had that were overweight and were obese. Naturally, the sessions were never passive ones. We always encouraged the group to participate, to move. And here we have an example. And even if it seems a chef, it's a colleague of mine, a family doctor. And he said that the table of the neighborhood worked very well, and it had a very good acceptance. And this place, these facilities, they were basically, they wanted to have workshops of healthy living, having healthy nutrition with kids so they could manipulate these elements, kinds of foods, and that they could cook and prepare these kinds of foods. And if you try to change to use this to have these workshops, don't use onions because they make the kids cry because they had to peel the onion and cut it. So the kids were able to prepare their own food, classify these types of food, and try them. And at the same time, we could work to other kinds of contents. We worked also, for example, of washing their hands, and that happened before the pandemic, but it was important for the kids to know how to wash their hands properly. And we opened the doors of this health center, and we had these visits of these teenagers for boys and girls in a way that could go there and to know what kind of services they were provided. And they didn't have to go to the healthcare center just when they were sick, but there were other activities of healthcare, of health promotion and healthy living. And another aspect, we went to the streets and we had theater plays, and we also had some group activities and dynamics with the mask. We can see here, they're wearing the mask not because of the pandemic, because they were painting the wall. And this was the pre-COVID situation. After that, during COVID, it was stopped for a while, but we had an opportunity, and in every crisis there is an opportunity. And the opportunity that came was that the school nursing image that became a reference acting in schools and in healthcare centers as well. From now on, we expect that we can develop other different actions or functions trying to help and assessing and the parents and the kids and the students, and to have preventive interventions in promoting health living and these schools. So I'm going to stay just for 5 seconds here. That is the page of the health promotion in Andalusia, and with all of the resources concerning nutrition and the sexuality aspects, and everyone that is able to access it, it's free for them to access. And that was it. Thank you very much for your attention.
Muito obrigada.
Thank you very much, Pablo. Thank you very much, Montserrat. We had many praises here in the chat, thanking for the sharing of experiences from this perception from the plan until the practice. Thank you very much. Now we are going to call the experience from Brazil, which comes from Minas Gerais state, from the municipality of Montes Claros, which will approach how the management makes an articulation in trajectorial one to qualify the organization of nutritional attention. For that, we invite Ms. Varelia Gonçalves de Araújo, a nurse specialist in auditing and health services, urgency and emergency, and technical reference in the programs of Montes Claros, Minas Gerais. You will have 15 minutes now for your presentation, and when there's only 5 minutes left, we're going to tell you. Thank you very much and welcome. Thank you. Good afternoon. Can you hear me well?
Sim, estamos escutando perfeitamente.
Yes, we can hear you very well. So now let's continue. So first, I'd like to salute you all, to celebrate you all. These days have been very pertinent discussions, and we need to advance and grow, and I believe that in our meetings we will be able to do so. Now let's help me, Vinicius, here. I will try to speak here of our actions here in Montes Claros within the policy of rehabilitation and nutrition, and I would like to present you where I'm speaking from. Montes Claros, Minas Gerais, and North of Minas. We have a population that is around 417,000 millions of inhabitants. Sorry, 417,000. We are the 6th municipality that has the most popularity here. Population, sorry. Now we're going to show you how it is our organization and a little bit of our organization in primary healthcare. Even with this population above 400,000 inhabitants, we have 142 CFs. It is a coverage of 100% of primary healthcare. We have a coverage that is 100%. We have 131 units of urban units, 10 rural people in the support part. We have a rural background, and then in those streets consulting, we have strategies, teams for healthy in the mouth, and teams for health units of primary health care. And within the primary health care, we have the strategic programs, which is where we deal with food and nutrition, which are the other programs for food, PSC, NutriSUS, and things about vitamin A. When we look through the Ministry of Health, there are other programs. However, we do not adhere due to our populational profile. Since we think about, how do we think about working this issue of food and nutrition? First of all, like in the next slide, it is shown, we try to understand a little bit what is a policy for food and nutrition. Then we understand that is about continuous activities, observation, how is the database of information that would describe the conditions, the food conditions of the population. And what would this be? Now, for next slide, please. It would be basically the evaluation of the nutritional state and also the consumption of the habits of the population. And then we would think how we would work this issue within a population that is big, above 400,000 inhabitants, in this financial issue. Since like it's shown in the next slide, we had a decree in 2011 that supported financially the structuring of this vigilance. There were many discussions, there were manuals. However, only in 2017, there was the habilitation of the municipalities to receive the resource. In this occasion, we were contemplated with 75 units And since we want, how do we want to work? First, our team, we tried, we dialogue, we did a situational diagnosis to verify what the municipality really needed to do, because we had the financial resource, but we need the diagnosis. We talked about with Imetro to raise all of our network. We united with many representatives, and we closed everything that was necessary at that time, because sometimes we think, no, we have the money, now let's buy. But what do we actually need to buy? We need to improve here by this. So there was this concern from the management at that time. Can you pass the slide, please? With this resource, we acquired to 100% of the network this platform, Balance platform, which was suggested that would be the producer of greatest quality in that time, the platform Balance. And then the child one, only with this observation, actually it is a scale, sorry, that we can have an advancement of a percentage of follow-up. I'm going to say here the program Bolsa Familia, 30 to 50% to 72%, and it did not stop there. We did many other raising of information and had the necessity of have more material. Now, next slide, please. We acquired this stadiometer for 100% of our community agents. We have now 817 community agents. All of them have a digital stadiometer, the digital scale to do these evaluations. Next slide, please. We acquired also, and this was not exclusively with the resources from this, with the municipality also had another thing from other resources, the food pyramid. When we acquired it, our models, here you can see our nutrition is working with it. It was in the moment where there was the change of this pyramid, basic pyramid, let's say, to that other one that is better. It had more detail, but since we had bought this, it was discussed that we would cancel this, and we took it forward because this change that happened in the pyramid would not hinder. Once it was changed, acrylic material, you can mold it. We also acquired this kit for healthy food, nutrition, because we have in all our basic care units. It has 27 items from games, these puppets of food, legumes, a kit that is very complete. This is our GTI. All these acquisitions that you saw, nothing was defined in a long way, let's say. We had to stop, think about this as we were sitting in our group, we took the product to the sectors, to the group. The management is part of this group, this work group of the sectorial work. We discussed, we saw the relevance of each material, and we try to adequate our units in this best way possible. And these meetings from GTI, they do not stay exclusively there in the table of discussion. As you can see in the next slide, we have control on all the areas. Our meetings are registered. All the programs that have a resource, when there is a documentation of the program, immediately we will model this book and we observe there if there was the passing of the resources we discussed, if there is the necessity of why this resource will be used. So each program has its booklet to see what the registers. This is passed to the meetings, the management It knows everything that was acquired, everything that was bought, participates in everything. Now, to improve the issue of food and nutrition, we need to go to our partners. We were able to have a partnership with Fiocruz to make a research here, and this is happening here. We have the participation of many entities. We had visitations in associations. It involves many partners through this research through Fiocruz. And also, with the aim to improve, there was the selection of Trilhas, which is a course from UNB in partnership with the Ministry of Health, where I did the inscription amongst the 40 selected. I was there. So we were following here, we were able to build this plan, municipal plan. We did the situational diagnosis. We're doing a book about the forces, potential forces, to be able to see what we can improve in our municipality in face of all the advancements that we have until now. And now we leave this questioning, what are our challenges? Our challenges. So it is the amplification of the coverage from this food vigilance to leave that look that we already had in this current management, to leave that look, to verify, to have this aim for the end indicators, to have a more critical look, directed look for a quality food nutrition, for one that is very effective. It is a challenge to also execute the programs about that approach P9. It's not easy. You need to kind of like a team that is working on it. A difficulty, one of the main challenges that we have been finding for a while is the access to the reports, because as I said before in the beginning, we had many advancements in all the numbers amongst all the people that are there. So, but we're needing these reports to make the analysis in our profile, populational profile, which is there. Only after this analysis can we deal to strengthen this agenda for food and nutrition. And after this analysis, then finalize our main plan of food and nutritional vigilance, so that we can do the sensibilization of the population, because we cannot think to do the sensibilization if we do not know the profile, if we do not have a structure for primary attention to meet this population, to take care of them. So now here I end here my presentation and put here my managers. This is only possible through the partnership that I have with them. I have a team for primary attention, from the coordination, the secretary, our director, our colleagues that execute the activities there. So next slide. Here I leave my thanks and I am available. Here are my contact information, and then let's do a better policy for food and nutrition.
Muito obrigada, Valéria.
Thank you very much, Valéria, for sharing your experience there in Minas Gerais. Now we are going to call for the next experience, also Brazilian, from Pernambuco, from the municipality of Camaragibe, which will talk about the program Saúde na Escola, Healthiness in School, for the strengthening and promotion of health. So now we call Dr. Ana Perez Pirenta, which is a dietitian specialist in family health and nutrition in primary health care, which is a master and PhD in Health and currently a Director of Primary Healthcare in Camaragibe. Ms. Ana Perez, you now have 15 minutes for your presentation, and when there's only 5 minutes left, we are going to tell you. Thank you very much. Good afternoon to you all. I thank for your invitation to be able to share our experience. I think we are sharing.
Sim, estamos vendo. Sim. Tá.
De onde estamos falando, né?
Okay, where are we speaking from? Camaragibe is in Pernambuco, a state from Northeast, from Brazil in Northeast. Next slide. It is in Recife. We have a territory of 52 kilometers, 52.9 square kilometers. We have around 158,000 inhabitants. We have 29 neighborhoods grouped in 5 political administrative regions and border with other cities like Recife. So here we have some touristic points which are very important. Now speaking a little bit out of the care network, primary care network, the services that we find in the first level of primary health care, we have the health vigilance and primary health care. We have 45 teams for family health care, 100% of coverage of teams from family health care, 5 teams in these groups, 18 teams of mouth health. We have a team from municipal program of immunization and in healthy academia gym in the secondary level. We have SEMEC Vera Cruz, Tabatinga, the maternity friend of the family. We have 3 CAPs, SAMU, the service of specialized care, therapeutical assistance, specialized centers, odontological center, labs, and rehabilitation center. For the hospital network, we use the state network. Oh God, I think it is a wrong presentation. It's not this one. Sorry, but it's not this one. I think it's the wrong presentation. Hello, can you hear me? Now they're trying to solve this small issue here with the presentation of the slides. We are waiting now for them to solve this issue because it's the wrong presentation. So Miss Anna is going to present the right one from her own computer.
Ok, a apresentação.
Sim, só coloque...
Is the presentation fine? No, just put it in the presentation mode, please.
Eu coloquei aqui, deixa só um minuto.
Ali a apresentação de slides.
She's trying to put in the presentation mode now.
Próximo ao Zoom tem
She's now teaching her how to do this, to put in the presentation mode.
Não, embaixo.
Perto do menos, depois do
Isso,
menos.
perfeito.
Eu coloquei, mas aí não foi. Foi agora?
Não. Ainda não. Mas acho que você pode seguir dessa maneira.
Tá, porque para mim aqui tá em tela cheia.
Mas aí ela vai ter que passar nos slides ao lado.
Pode seguir.
Now, okay, you're going to continue with the presentation.
Como a gente vai falar? Porque eu estava
Since she's talking about her presentation was wrong, and now she's going to continue. So since we are going to focus in the experience of the program Health in School, just bringing a little bit which are the objectives of this program. So it contributes with the integral formation education of students through the promotion and prevention in healthcare, and give the integration articulation between education and health. Currently, we have 13 thematic actions present in the program Health in School. Now they're trying to fix that, the fact that the slide cannot pass. Now it is working.
Vou aumentar pouco, tá?
Tá ótimo, obrigada.
Okay, they fixed the problem.
Tá sim, pode seguir, obrigada.
Então, atualmente...
Currently, we have 13 thematic actions. The theme from COVID got on recently. We also have within PSC the program QC Saudável, which has the objective to prevent and face obesity. And we also have NutriSUS, which is directed towards children with small weight, which is a program that of micronutrients for children in preschool time. Currently, these are the 13 actions which are foreseen in the program Health in Schools. As I said before, Camaragibe is located in Pernambuco, a northeast region of Brazil. Here I said before, now we are going to this attention network. So primary healthcare has a coverage of 100% with 45 teams from family healthcare, others in NAGI, others of buccal care, and one gym of health beyond the program of immunization. The education network, we have 28 units, educational units, municipal education units, which adhere to the program, 11 educational units from the state network, making it 39 educational units with an estimative of more than 18,000 students. This is our target group. So speaking a little bit about the strategies that we have been developing here in the municipality, we begin by talking of the evaluation and planning workshops, which is one of the most important ones in this planning, where we perform these workshops with the professionals from vigilance and health, primary attention, and the directors from school to make this evaluation of the previous year and the planning for the year that is beginning right now. We plan jointly the themes which will be approached in each school, considering that we will not be able to work with 13 teams in all schools. So within this moment, we begin to do this joint planning of systems, and then schools, alongside with the teams of family healthcare, they elect which activities of the teams that they will try to develop throughout the year. And also, we do the programming of which actions will be performed jointly and what themes will be included in this political pedagogical program of education. Also considering that we will not be able to do all the actions together. So there are actions that will be done jointly and ones that which education will be performing within their project, political pedagogical project. So these teachings began in 2017. So in 2017, we performed 2018, and then 2019, unfortunately, it was not possible because there was a problem of the exchange of management, and then we were not able to perform. It was planned, but they were not able to perform it. We took it again in 2020, in 2021, 2020, we were able to do it before the decree of the pandemic. Unfortunately, we will not be able to put in practice all the actions that we had planned, and then we need to reinvent ourselves. And in 2021, we performed it, but since we were already still in the middle of a procedure of a pandemic, that would make it not possible for us to have many present meetings. So this was performed between the coordinator of PSE from health, in which the directors of the school, so that they would be able to do the planning. And then later, each school would gather with its team or family health and do their planning of the actions for the year of 2021. 2022, it still did not happen. It was foreseen for February now, but also we have an increase in cases, so we will try to postpone it, and we're going to perform it in March 16th of 2022. This is a teaching that we consider as very important, considering that
Você tem 5 minutos.
Ana, you only have 5 minutes. So considering that it is a teaching where we will do a planning and organization of the actions of the entire year, and it's, like I said before, done jointly. We also have, as an advancement, the implementation of the work group, municipal intersectorial group, where we gather all the secretariats involved for the development of these actions. And then within these actions that we perform within the PSE, they're all shared. All the professionals of the teams or family health, they participate, they plan and execute. All the professionals from NACI, the health gym, vigilance and health, those who combat endemics and argovirus, the professionals from schools, they also participate in these moments. In relation to food and nutrition, it is important to highlight that we perform monthly meetings between the nutritionists to discuss the themes related to nutrition, and we also put the fencing to obesity as a central theme in the nucleus to promote health. We are also building the municipal plan of obesity in the implementation of the strategy Alimenta Brasil, and we have began an approximation between the nutritionists from NASP and education to discuss school food. Due to the pandemic, we were not able to advance because schools were not offering the food because they were in a virtual mode, but we will retake it from now. Within the action from Crescer Saudável, it is important to reinforce that we perform the anthropometrics and this measurement in children. And an important data is that in 2021, we were able to make that 99% of the educational units would perform this action. And it was a total of more than 3,000 educators who were evaluated. Students, actually, they were evaluated. Beyond Crescer Saudável, in the issue of food and the bodily practices, we created a circuit, a healthy circuit. All of this is due to the planning of the teams of primary attention alongside education. So they put this in practice in this educational environment. So we also have the issue of the school plantations for you to see all the steps for this feeding. All children will plant, they harvest, they prepare their salad, and they feed themselves with what they have produced. As it was said before, we need to think about primary healthcare, which is ample and which we need to have a vision of a whole. So I also brought other actions that we have been developed. I did not bring them all because it would not be possible, but some of them which called the attention. So the work from hearing healthy and eye healthiness. So we need to call for the attention to the presence of ACS, which was trained to do this visual acuity, accuracy, and to see this, and we were able to create this booklet for registry where we take alongside the school all children who were registered, and we do this booklet, and the children who do not have this cartão SUS, we do this integration, and when we emit this cartão SUS to deliver to the family, and we leave it registered within this booklet caderno to make it possible to extract in eSUS, which is online SUS. Also, it is important to have a gain this year that we had because it was within the sexual and reproductive rights, the law that was sanctioned by the mayor in the program of free education in schools, public schools in Itamaraty. And it's important for us to talk about it because we need to make everybody that everybody is in schools, and we need to think about all the aspects. Okay, so even for us to talk about nutrition, we need to think about other aspects.
Okay, I'm concluding here. Okay, so during the pandemic, we had a joint plan that we created this plan by providing educational materials that would be used, and education worked remotely. So here are just a few examples of healthy eating. So kids worked with their parents and then they sent the pictures, and the program Literate Children, in which they work with recipes for the the process of learning how to read, and some other strategies that we had, which was the vaccination of healthcare professionals in schools, as well as the kids from 5 to 11 years old. And to thank, I'd like to mention Paulo Freire's sentence that he says, there is always something to learn. And on behalf of all the healthcare professionals, I would like to thank the coordination of PSF that has made the difference here in Camaragibe. Thank you.
Muito obrigada, Ana.
Thank you very much, Ana, for sharing your experience in Camaragibe. Now we're going to have the international experience from Trinidad and Tobago. And I'd like to invite LaDonna Guston from the Interim Director of the Healthcare Directory in Trinidad and Tobago that's going to talk about the HEART initiative and intervention to promote healthy habits, healthy lifestyles. You have 15 minutes for your presentation, and when it will be 5 minutes before the end, I'll let you know. Thank you very much and welcome.
Good afternoon, everyone. Are you all hearing me clearly? Thank you. So I'm going to start sharing my screen so that we can see our presentation. This afternoon, I would like to say thank you to everyone for giving us the opportunity to present to you today. And also, I'd like to say thank you for sharing your experiences with us also. So we appreciate that. So my name is LaDonna Galston. I'm the Acting Director of the Health Education Division at the Ministry of Health. And we're going to talk about the Hearts Initiative in Trinidad and Tobago. So an overview of Trinidad and Tobago. Trinidad and Tobago is a twin island republic with a population of 1.3, approximately 1.3 million persons, and there is a male to female ratio of 1:1. It's a very ethnically diverse population with a diverse culture. The health situation in Trinidad and Tobago shows that non-communicable diseases continue to be the main cause of mortality in Trinidad and Tobago. Heart disease is the #1 cause of death, accounting for about a quarter of all the deaths annually. In 2016, cancer mortality rate was 108.7 per 100,000, while the diabetes mortality rate was 110.7 per 100,000. The health system in Trinidad and Tobago is designed where the Ministry of Health gives leadership and governance and sets the policies and legislations, the goals and the targets to be executed. There are 5 regional health authorities, and you can see them marked out in pink on the graph. Tobago, which is a smaller island, is 1 regional health authority, and there are 4 in Trinidad. So these regional health authorities are semi-autonomous bodies, and they are responsible for the delivery of services. There is free health services for all in Trinidad and Tobago, whether you are native to Trinidad and Tobago, or if you are migrant, the policy holds the same. Everyone is entitled to free health services. And we have a network of 102 health centers. Also in the RHAs, we have 12 hospitals, and all RHAs have a referral hospital, at least one. There are 1,842 physicians in this service, and then we also have the private hospitals and private physicians that also make up part of this component. So the Hearts Initiative in Trinidad and Tobago, the Hearts Initiative, Trinidad and Tobago joined the Hearts Initiative led by PAHO WHO in 2019. This initiative targeted the strengthening and the management of NCDs in general and cardiovascular disease in particular in the primary health setting. The purpose of Trinidad and Tobago Heart Initiative was to strengthen cardiovascular disease management in primary health care in Trinidad. And we are doing this by targeting hypertension and diabetes control. So Heart started in 2019 with 5 of those health facilities of the 102 that we have. 5 of them were on board and were sites for Heart's execution in 2019. At the end of 2021, we had reached 48 of those health facilities. And our aim is, our target for 2025 is to be able to say that we are using the Hearts model in all of our 102 health facilities throughout Trinidad and Tobago. So how have we used Hearts? We have used the Hearts model from the WHO and PAHO to improve the existing delivery system. And that has been very effective in Trinidad and Tobago. And we want to thank PAHO WHO for bringing to us this HEARTS model. So the healthy lifestyle, the H component of the HEARTS in primary healthcare, right? This focuses on the nutrition and physical activity represented in the healthy lifestyle components of HEARTS. It is executed by way of two main avenues in the primary health care. Firstly, the chronic disease self-management program, which was introduced only under the HEARTS model. So that only came about because of HEARTS. And the second system is the referral system, where physicians refer clients, patients to dietitians and nutritionists who are available in every health facility. These dietitians and nutritionists work on a system where they work with a cluster of health facilities, and they have structured approaches to appointments so that clients are referred and given appointments, and they can have access to these dietitians and nutritionists, all free of charge. So the self-management program, which I'm very excited about, and we have been working a lot with, and WHO PAHO, you will see more on their website concerning the self-management program because they are doing a lot of reporting on it. The Ministry of Health, the Health Education Division, in collaboration with the Pan American Health Organization, introduced virtually because of COVID-19, the chronic disease self-management program in each regional health authority in 2021. This program under the HEARTS initiative is an educational workshop. It's designed to provide self-management skills for persons who are living with one or more chronic conditions, for example, diabetes or cancer, heart disease or arthritis, for example. All right, and the chronic disease self-management leaders were trained in the Stanford Chronic Disease Self-Management Program. This program was facilitated by PAHO, and it aims to improve the lives of persons living with chronic diseases. And we have seen benefits. We are doing analysis now, data collection, but we have been seeing improvements because of the self-management program. So under the self-management program, we want to examine nutrition in primary health care. So the nutrition components of the self-management program focuses on topics such as healthy eating, reading food labels, and preparing healthier foods. Clients can still have access to sessions with a registered dietitian or nutritionist on request by them or by their physicians. So these are the components that are delivered in the self-management program. So we want to ask the question, has HEARTS strengthened the health system in our country? And we can only answer by saying yes, because it has assisted in building the human resource capacity, where approximately 300 health staff have been trained by the HEARTS, by local master trainers, and through PAHO's virtual campuses. Trinidad and Tobago hypertension treatment algorithm has formally been approved, and implementation commenced in the HEARTS sites. And important to note is that we made amendments to the Ministry of Health drug formulary so that this could be effective. HEARTS has assisted to strengthen our registries. So we have been able to review our hypertension registry, and that has been completed. A project to standardize and upgrade registries was initiated in 2021.
Você tem 5 minutos.
Sorry, you have 5 minutes.
Thank you so much. So it has helped to strengthen the linkages between primary and secondary health professionals, which is very important in the development of the hypertension algorithm and introduction of diabetes protocol. In COVID-19, we have been able to introduce telemedicine for managing NCD clients, and we have been able to pre-package and do curbside pickup of medications, and pharmacies have been implemented. Importantly, we have been able to train and certify the first cohort of trainers in self-management and have begun rolling out the training in the communities. We expect another cohort to be trained very soon in 2022. So the lessons learned, we will be able to build strong governance structures. We were able to emphasize capacity building, the use of evidence-based protocols, ensure mechanisms for consistent supply of essential medications, ensure public, private, civil society collaboration in the process, which is very important. And we have been able to strengthen patient self-management. In conclusion, I want to leave you with a quote from one of our Heart's biggest supporters and pushers in Trinidad and Tobago, who have worked very hard with Hearts, Dr. Rohit Doon. He's the advisor for health promotion, communications, and public health in Trinidad and Tobago. And he stated, "Our experience here in Trinidad and Tobago has led me to believe that the Global Hearts Initiative is a universal good and has the promise of and the potential to become one of the most impactful public health interventions of our time." Thank you very much for giving us the space and the time and for listening.
Muito obrigada, Ladonna.
Thank you very much, Ana Ladonna, for sharing your experience with us. And now, to finalize this moment of presentation, the experience will come from Portugal, and we will approach primary healthcare in Portugal. And what were the measures that were structured for a better environment adoption? So we invite Dr. Maria João Gregório, nutritionist, and doctor in sciences of human food consumption by the University of Porto in Portugal, and the director of the National Program for the Promotion of Healthy Nutrition. And Dr. Maria João, you'll have 30 minutes for your presentation, and 5 minutes before the end, we'll let you know. Thank you very much and welcome here. Thank you very much. Good afternoon, everyone. I would like to thank everyone for the invitation to share in this seminar, and I congratulate the organization for this very interesting event. I'm going to share my screen.
Deixem-me só colocar em modo de apresentação e acredito que neste momento...
And now I believe you can see the presentation, right? In full screen. Yes, we can. Thank you. Perfect. So, in fact, I'm going to make a presentation that is going to approach the National Program for the Healthy Nutrition in Portugal, and what kind of actions we're trying to implement here that are connected to the modification of the nutritional environment, which is one of the focus of the program throughout the past years. And I'm also going to try and identify what are the kind of actions that within the program that have an interface between primary healthcare and that I will likely mention once this designation here in Portugal, the denomination will be this, and that will show up in my presentation. In Portugal, we have a national program for the promotion of healthy nutrition, and that is different from Brazil. And we just have one specific program, and it's been going on for the past 10 years, starting in 2012, and it was a priority program and health program that is developed within the National Plan of Healthcare. And the National Plan for Promotion of Healthcare and for promotion of healthy nutrition or eating habits is part of a program, a group of programs that deals with chronic diseases, and also the main chronic diseases that are prevalent in Portugal. The mission of this program is, in reality, to improve the nutritional state of the population, trying to change the nutritional environment on one side, and also to educate the population to make better choices of eating choices. The program is divided in 5 major areas, and we consider them the strategic areas. The first one is connected to having an information system that allows us to collect data about nutritional status and its consequences. And a second area is connected to the change in the nutritional environment. The third one is trying to promote the literacy and education in this area. And the fourth area that is connected to the importance of the intersectorial actions and transversal actions as well. And the last area, which is connected to the need to improve the way of acting of different professionals, not only healthcare professionals, but also other areas that can influence and food aspects. And when we look at the structure of the program, I would say that the 5 areas that I mentioned here and the previous slide, 3 of them are very important, and one of them have to do at the intervention of the level of the individual, trying to enable individuals to make better choices. The second one is the second aspect, which is the change of the environment. And the third one, it's connected to the intervention in relation to healthcare services. And this is one of the areas of the program that has been less improved, but it's one of the areas that we really want to strengthen in the next few years. And on the other hand, we have 2 areas that are transversal, that are connected to information systems and the model of intervention between different sectors. And associated with this model of intervention that is intersectorial, in Portugal, we don't only have this national program concerning health that is developed by the Ministry of Health, but also we also have an integrated strategy for promoting in nutrition, healthy nutrition, that also encompasses our other areas such as agriculture, economics and finances, education as well, and many other aspects. So therefore, this strategy tries to put healthy eating habits, include healthy eating habits in all public policies. And that's why it's aligned with the principles of WHO of health in every aspect, in every political aspect. So I'm going to present some actions that we're trying to implement over the past few years. More recently, we have legislation that is specific to determine the nutrition or food offer, especially public spaces and in schools and in the national healthcare system, trying to encourage these foods that might be provided in these public spaces. In 2016 and 17, actually, we created a tax on sugary drinks that in reality is a tax that it's charged only in fizzy drinks and carbonated drinks with addition of the sugar and the amount of sugar that these drinks have. At a first stage, this task had only, it was 80 grams, and now it has four different stages, levels, because one of the results that was obtained by this tax was the encouragement of changing the composition of these food products. So the goal of this tax was to encourage the changing in the ingredients of these drinks. And in reality, I present here some results that were achieved in this chart. And we can see that it is possible to analyze the distribution of sugary drinks concerning their sugar content. And it's possible that by comparing 2016 to 2020, there was in reality a decrease of the proportion of sugary drinks that is over 8 grams per 100 milliliters. This tax was not only capable of encouraging the changing in the composition of these food products, but also managed to foster a reduction in the consumption of 15%, around 15%. So that was the decrease that took place in the sales of these drinks after the implementation of the tax. More recently, we also designed a plan for the food products change components and that separated into categories, for which we proposed a reduction of sugar and salt. And for this plan, we took in consideration the suggestions of the European Union that we recommended for countries to have plans for the change in the components of these food products. And we also took into account the data of consumption of food products considering the data of the last national report in our country that allowed us to identify which foods and which products would contribute to for the ingestion of sugar and for the Portuguese populations. Therefore, these were the products that we identified, trying to establish targets with a defined period of time to change. So here I have some results that we managed to achieve. For the categories of food products that are included in this plan, it was possible to check the reduction of 11.5% in the average content of salt between 2018 and 2021, and a reduction that was similar also concerning the sugar content, with a reduction of 11% in the same period that was analyzed between 2018 and 2021. And the result of this process, it's been estimated that between 2018 and 2021, the total volume or the amount of salt in these food products was reduced and 25 tons of salt and 6,000 tons of sugar. And the last thing I want to mention concerning the measures that we're implementing for the change in the food environment, we also wanted to say that starting 2019 in Portugal, there was a law that was approved that introduces restrictions concerning advertisements directed to kids. And I would say that in Portugal, throughout the past few years, it was possible to implement this group of that was made bigger of measures, and in reality, over the past few years, we're creating more and more evidence that inadequate nutrition was one of the main determinants of health problems in Portugal, in the Portuguese population. And the data that resulted from the surveillance system of child obesity promoted by the WHO in Europe, it also allowed us that the prevalence of obesity and the overweight and compared to other countries in the European Union, Portugal was one of the countries that presented a more elevated prevalence of overweight and obesity. And all this data gave us the perception and showed the political powers that it was necessary to take measures in this area. And also the importance of public policies that should have so we could effectively improve the nutrition of population, considering that measures were necessary that were not necessarily geared towards the healthcare system, but also that should alter the nutrition environment that determines the choices of the population.
Passing now to what is the options and of this national program for food and good nutrition. With the primary care, I will identify 3 great areas as being those where there is a greater interface between the national program and the actions that are developed by the cares, by the primary attention in health. And with the focus of the program, even these first 3 years, has not been in this context, but it is clearly one of the areas that we would like to work on in a more intense way in the future. But now I would highlight these 4 great areas, namely the role that the cares for primary health have been having in the level of vigilance, in health, in what we are talking about to food and nutrition, namely in what about the vigilance system of obesity, child obesity, who's going to take resources. It is in fact performed by professionals from the primary health care, and also a system of a monitoring for food insecurity, which was also created during the last economic crisis in Portugal that happened in the period of 2011, and then was also possible with the professionals, health professionals and the resources and the cares of primary health. It was also possible to implement a system to monitor in this area On the other hand, the cares of primary health also have a very important role in the school health. In Portugal, we have a national program about school health, and it is operationalized, implemented in a regional level and local level, also by the cares for primary health. Lastly, we also have been looking forward to reinforce the capacity of the primary health care in the level of the production of healthy food, developing some documents, some manuals for intervention in this area, as also we have been looking forward to promote an improvement in identifying and intervention in the area of pre-obesity. And then I was going to detail some of these initiatives. The first one is about the area of the health in school, and in Portugal we have a national program, specific one for this area. We have this mission of that all children and young people to have the right to education and health, and can have the opportunity to frequent a school that is a producer of health and well-being. And when we look to the strategies of this program, we identify two areas, very important areas, like, and with a highlight to the area for the production of healthy food, namely the access of training, and the one for food and school environment, this modification of this environment and within this program, National Program for School Health, with the promotion of healthy nutrition is one of the areas of intervention which are considered to develop in the capacity in training of the community, educative community, and in a level of the healthcare, in which there are teams of food security which are integrated in the public health, which are units which exist in Portugal in the structure of the cares for primary health care, in which we have teams that allocates 30 weekly hours for each 2,500 students, and then they develop all this work in a school context. In this slide, it's just to show the vigilance system of child obesity, how it is allowing since 2018 to do this vigilance of child obesity in Portugal. And also it is a system that takes data in school context and also with professionals that are part of the cares of primary health. In this slide, which represented the study of the monitoring system, which we implemented during the period of economic crisis to evaluate this food insecurity in Portugal, and that also was performed in the context of the healthcare, primary healthcare. It's relatively true that to about the initiatives that we have with the objective to reinforce the promotion of healthy feeding in the National Service of Health and the primary healthcare. In 2021, we developed a model to brief counseling for healthy nutrition, which follows the model of the 5 A's and defines all the procedure and all the model that must be implemented in this context. This model has an algorithm that defines the different professionals must do in each in each of the steps of the model of the 5As, there is an approach that is very brief, and this model of brief counseling includes also the jointly of materials that later will make it easier to do the counseling that the health professionals. It is a model that will be applied essentially by the doctors, family doctors, and so it is an approach that is brief and relatively generic about the promotion of healthy nutrition. In the same line of the previous model, we also defined a model of counseling for healthy nutrition directed towards the context of pregnancy. So here, the objective is also to assure that the pregnant women also have access to the counseling to have a good nutrition in this phase that determines this life cycle. And lastly, within these initiatives that I am highlighting in the environment and what it is the interface between the National Program for the Promotion of Healthy Nutrition and the cares of primary health, to also say that we have developed an existential procedure indicated by pre-obesity in adult people, and that the objective is to implement a model to identify and intervene in this area, promoting to have an anthropometric evaluation in all consults which are performed by the doctor, family doctor, and that later that it is given the opportunity to, so that people with pre-obesity and that are available for changes can effectively have access to a plan, individual plan of care. And this is, in fact, one of the areas that seems to us to be fundamental. And lastly, I am almost finishing my presentation to say that we also have some areas identified as areas to work in a future. In this context of the primary care, we have the intention to implement the identification of nutritional risk in cares of primary health, directed specifically towards groups which are the most vulnerable population, particularly to old people. And we also have looking to elaborate an integrated plan of care for obesity that aims to outline a joint of answers to different levels of this prevention and intervention in a phase that is more initial of the disease, and here to have the intervention in more advanced phases in which the disease already progressed. So we intend to have an integrated plan encompassing different approaches for the treatment of obesity and also prevention, but integrating also the many levels of care, but with a focus, a particular focus for the healthcare, primary healthcare. This is the last slide that I have to present. This will be a model that we aim to follow to implement the identification of the nutritional risk in old people, applicating in a tool to identify the risk, in parallel to the scale that makes it possible to evaluate this. And due to that, to promote a model, reference model that makes it possible to differentiate the people that are identified as risk one for consultations, nutritional consultations. So with that, I finished my presentation. I hope that I was able to fulfill my time, and I am available for all the issues that may arise. Thank you very much.
Doutora Maria João, a gente que agradece.
Dr. Maria João, we thank you very much. We have many praises here. Your speech was very good. So now I'm going to make the invitation to debate the experiences. Ms. Graziela Tavares, family nurse and advisor from the Department of Health Promotion, DEPROS, from the Ministry of Health from Brazil. We thank for your presence, which will help us on reflecting how these international and national experiences can enlighten and inspire this scenario of food and here in Brazil, considering the local and the territorial diversity. Ms. Graziela, you have 10 minutes for your comments. When there is only 5 minutes left, we're going to tell you. Thank you very much and welcome.
Gabriela?
Oi.
Não está habilitando a câmera.
Para Graziela? Eu estou tentando falar com ela, um segundo.
We are waiting because there seems to be a technical problem. You're going to wait a few seconds now.
Tá. Deixa eu ver. Então, Graziela está com um problema.
So Graziela is having a problem to make the connection. We're going to change the order now. And now we're going to begin making the questions. And then Graziela will try to get in with us. So now we gather the questions from the chat. And then I will try to ask for that each person that will answer make a brief speech of at least 2 minutes, and then after answering can already do their final considerations. So now we once again thank everybody. So firstly, for Pablo and Montserrat, the question that arose was, do you already have results about the indicators, health indicators, and about the addition of students to the activities? Now, for Brazil, we had the question for Valeria was, Valeria, do you emphasize the new recommendations of the food guide on using the pyramid, since this one does not separate the food according to the level of processing? For Ana Perez from Pernambuco, the question was, which were the greatest challenges to be able to effectivate the actions for food and nutrition so that they could be included in the pedagogical plans of schools? For Trinidad and Tobago, we arose the questions for if there is participation of the community in the actions of the health system. And now for Dr. Maria João, the question is, beyond the approach alongside the students, how is the one by the parents or responsible ones? We thank, and now I think we can begin with Pablo and Montserrat. Thank you very much. So thank you very much. In relation to the indicators of results in health from the actions in the objective way, currently we do not have concrete indicators through which we can measure the impact and we can advance with the program in 2015. Only some global indicators from the researchers, regional researchers from health. Okay, be amongst the aspects that are at exit is from the physical activities and the type of nutrition. And also, that's why we did, in which we have an advantage that we are going to begin this year. We did the compendium with the University of Cordoba, in which we're going to do a pilot project of current themes, and now we're going to measure the situations in the impact level and how we are going to develop this in the indicative scope, especially in the population's health, in case from the population from the adolescents. And then in relation to the implication of what we have is that, in fact, we have activities that, yes, they will be, that we have many participations. They are activities that some of them come from the traditional, from the curriculum, educational curriculum, traditional one, and then some will be developed, and then with their families, that to have the interaction, that it be the student with their class and then with the family. I don't know if we answered the question or if there's something more. If you, Montserrat, wants to add something, well, I would like to add that in the macro scope, I could not say numbers, but we did not prepare this, but in Cordoba, we have a relationship of what was said in the exposition. We have idea that some follow-ups, monitorings, and supports from people that we have been observing in the program itself. So in a small term, yes, we have evidence of an increase in the physical activities, and let's say diminishing of the excess of wave of people that include in this that are included in this program. What happened is that, sincerely, the data, we do not have them ready here, but we have the evidences, yes. Thank you very much for the question.
Muito obrigada. A gente passa agora a palavra para Valéria.
Em relação ao guia alimentar, ele é usado em todos os atendimentos, todas as
We do not have a sound. Oh, sorry. Then we did the distribution of 100%. They have the food guide, and remembering that all the actions that we're going to execute in the municipality, they have the team, nutritional team, that helps in the elaboration of those who are exclusively from the primary attention to the ones that are in partnership with primary attention, to a program that goes to the school. There is the team from PENAI, from food nutrition, that also has the participation from health. I think I answered the question. Okay, thank you, Valéria. Now we're going for Ana Pérez. Thank you very much for the question. I would say the following: not the challenge. I think that what helped us, not only in relation to food and nutrition, but in the PSE as a whole, all the themes, that the management of education understands the importance of these themes and the importance of working this within the pedagogical project. And the issue of the challenge for us, it was not happened because we have a management that understands this. So we try and have been doing this to insert these actions within the education. So I think that's more important to talk about the importance of the management of education, to understand the importance of putting this within the theme, than to speak about challenges. So I think that we need to approximate health from education and make it possible so that education understands the power that it has for us to be able to implement all these themes within the education, so that we can, with certainty, have more healthy individuals, and these children, they already take this for life. So I think that this is one of our greatest objectives. I'd like to thank for the participation, and I'm available here. The municipality is open. If anybody wants to come here, exchange ideas, we are available here. Okay, now we're going to pass to Ms. Ladonna.
Hello, everyone, again. Trinidad and Tobago, we have learned that it's important to collaborate with the community. The question was if there's participation from the community. So under the HEARTS initiative, the self-management program, where persons learn how to eat healthy, they learn about how to improve their choices in food and read food labels. Definitely, we use persons from the community, where community leaders from NGOs, churches, other religious organizations are used and trained as leaders who would be part of the program, and also the persons from their communities get to advance names of persons with NCDs that can learn in the program. So definitely, yes, the community is involved, and in order for health to improve, for us to improve the health of people, it is always essential to incorporate the community.
Muito obrigada.
Thank you very much, Ms. Ladonna. And now I pass the floor to Dr. Maria João. Thank you very much for the question. In fact, which will be one of the challenges, how can we look for the parents and families to considering this is still a challenge, a great challenge that we have, but I also consider that the intervention with the children in itself already makes it possible to reach the parents most of the times. But effectively, for example, during the pandemic period, we were able to optimize the communication means, digital communication means with the family. And with that, we were also able to send information and some material that we were developing throughout the period of the pandemic to the families, through the schools, and with a very positive receptiveness. And in Portugal, the associations of parents also have a very important weight, and I also believe that your involvement in these initiatives and with the role that is more participative within the design of interventions within this area can eventually be a possibility of being able to involve more parents and the families in what would be the activities for education for health in schools. In Portugal, we also have been testing other approaches, some projects, pilot projects, which also use the new technologies to be able to reach more easily the parents and be able to promote the interaction with parents. Particularly, we had a project with some success in Portugal that developed a platform, a digital platform that worked with like a social network for families to share their challenges and activities amongst the different schools and families. And this was also an approach that promoted more involvement from the parents and those who are responsible for the education, but it is still one of the greatest challenges that we also feel in our country.
Muito obrigada.
Thank you very much, Dr. Maria João. Thank you for you all who participated here, answering to the questions, to make this debate. I'm going to make the invitation to Graziella, since the technological issues was solved, for her to make her comments in the experiences that you brought. Thank you very much, Graziella.
Pronto, agora sim, boa tarde.
Okay, now I can speak. Good afternoon to you all. Finally, I was able to arrive here. We were able to begin, and I think that it was a very rich afternoon, like during all the presentations from the seminar. I think it is a continuity that we have, and so I talk about from the Department of Health Promotion from the Ministry of Health here in Brazil. DEPRUS was formed. It is a department, a new department created alongside the Secretariat of Primary Health Attention in 2019. So with this creation, the policy of health promotion comes for this space, for this department, and we have as a guideline to coordinate and orient this organization for actions to promote health. So we have there a composition of 3 coordinations here in the department, which is the one to prevent chronic diseases and to control the use of tobacco and physical activity, food and nutrition, and those who are organizing all this seminar here. We have a part of intersectorial programs, which I think is a very important focus that has been presented in all the speeches here today, which are intersectorial programs that are within the advisory of the cabinet for the importance that we see in it. So putting there in the space that we find ourselves, I think that during the entire seminar, some speeches were brought for primary attention, for primary care. So we have a great coverage in Brazil. We have 47,000 themes, more than 250,000 communitary agents of health. And I think that this is the collocation of this network of health as part of the SUS and the APS gathered so close to it, and the team as a whole, but mainly the role of a communitary agent, health communitary agent, that compared to other teams from the world of primary healthcare, is one of the few places in where we have this member of the team that's very important. So this proximity with the territory, this possibility of the teams being present in the day-to-day basis of the population, meeting the spaces, knowing their vulnerabilities, the necessities, I think it helps a lot in this diagnosis, in this proximity the team for primary healthcare has to make all this articulation in the territory, mainly thinking about the issue to guarantee food security and nutritional security also, but also as a part of the procedure of these teams. So in the middle of all these actions that the teams have been developing, we understand that it has a potential, like we have seen in the presentations, representing here the countries. Ana from Camaragibe, and also Ana from Camaragibe, and Valéria from Montes Claros, Minas Gerais. I think they bring this a lot as a program that is specific for food and nutrition, or a program health in schools that is similar in some aspects with the experience that Spain brings, that Andalusia brings, that is all this scope of possibilities to insert that we already been doing this work, intersectorial work, and also integrated work. I think that we can punctuate there, put there that there were appearing in the discussions and in the presentations. I think that it's not only to be intersectorial. I think that this integration for the actions is also very important. So when the healthcare team is strengthened and talks with the education team and with other sectors, and they think jointly. So when the greatest challenge is for us to be able to put the discussion of health habits as a whole, and also thinking about the food and nutrition, we bring this issue of how to insert this in all the school activities, not only as a punctuation for a moment, for a lecture, or a specific action, but how do we in fact bring this to the discussion of the day-to-day basis, to the classes, to the canteens, to food, thinking about the school plantations, how do we build this so that the student can already grow knowing that where the food comes from, and that there is a discussion in classes of how it's healthy. In the classes, for example, mathematics, how do I insert my food here with this focus? When, like I think Anna said, I did some notes here. If I'm sure it was Anna that talked about the issue of including in the political pedagogical plan. I think that this is very important, and bringing here, I think that my time is ending, and also bringing many issues. I think that Portugal brings the issue from illiteracy, how it's important for us to do this education, this information of food and healthy and adequate nutrition, the healthy environments. I think that the scope that we have of actions and all the path that we have been following in Brazil with many offers, the program Health in School, we, for example, it's going to be 15 years old. So we have a long path to articulate and organize this program. In the last cycle, we had more than 97,000 schools, and the number of students, 23 million students. So we think that this is a scope that is very broad, and if we can take this beyond the students to the entire school community, this talk about the environment, food, I think that this gives a great potential for us to have an impact in the future. So I think that bringing a little bit of the issue, which was very spoken about children obesity. So we have a project, a strategy for prevention and care for children's obesity. And I think that it comes to aggregate. We already have an interest growing healthy for these actions, thinking about going to the school, kindergarten. But I think this amplifies the promotion, be it for the consumption of healthy foods or the issue about behaviors. So we have been doing some offers to be able to try to amplify the scope and the potentiality that the team has in the territory to work on this. I think the issue for the participation of the community and bring together to have this discussion, I think it is very important. And sometimes I am a nurse, family nurse, and when we go to the day-to-day basis, we do not see all the potential. We stay focused in the work procedures, or the actions, but we also think on how we can in fact articulate and to be able to aggregate partnerships in the territory that help us to foment this environment, this articulation for the environment of the discussion of food, adequate food and nutrition. So I would like to comment in my last minute the issue that Trinidad and Tobago brought. We did the addition to the HARPS Brazil. We did it last year, in the end of last year. So it's good to see the experiences and everything you bring, all the contacts, the potency and the potentials that it have. I think we did the launch of the cardiovascular strategy in the country here in Brazil. And within it, a small piece of this strategy is heart. So we get into the access of qualifications for the clinical approach, the protocols, teachings, and also the management. But without a doubt, I think I want to thank for all this learning that was here and to congratulate everybody that was present here. And it seems that 10 minutes is very small. I'm just looking here. But I think that the Department to Promote Health is available, like all the coordinations, to improve and amplify these institutions. I think that this is what I wanted to talk about.
Gabi, ó.
I finished on time. Thank you very much, Graziela, for all your points that you brought here to contribute with the debate. We also wish that the discussions throughout the event, they can help in the construction of an integrating model for the actions for food and nutrition in the procedure of work in the organization of primary health care, be it in a national level or an international level. We also thank for all the exchanges of experiences that happened here in this afternoon. Certainly, this exchange will be an inspiration for those who are following us and that work with the implementation of the public policies in food and nutrition. Now, it's with great satisfaction we are going to share the collective construction and the delivery of this second International Seminar of Food and Nutrition in the Primary Healthcare. We invite for such Dr. Gisele Bortolini, General Coordinator of Food and Nutrition, ASEGAN from the Ministry of Health in Brazil, to read the second letter of Brasilia. Thank you very much, Gisele. Hello, thank you for you all. I think we all notice how Gabriela is happy. She's very happy here with this seminar, the possibility to exchange experiences with other countries. Certainly, there are some countries that we already have been cooperating with. I'm seeing here Maria João. We also have others here that we have an interest to cooperate with. So I'm going to read the second letter, elaborated with the contribution of all of you who are here collaborating. So throughout these 3 days, we received the contributions of you, so as well as the other partners that were here with us. To elaborate the second letter from Brasilia, directed towards the actors and formulators of decision makers, managers, and professionals in the area of primary healthcare and food and nutrition and health, I'm going to read the preliminary version of the letter that consolidated the more than 100 contributions that we received, as well as the main debates performed in the second seminar, International Seminar of Food and Nutrition in Primary Healthcare. The second letter of Brasilia, considering the objectives for the sustainable development that include to end with hunger, reach food security, and improve nutrition and promote sustainable agriculture, considering the decade for the action in nutrition from the UN that recognizes the necessity to end with hunger and avoid all types of malnutrition in the world. This global scenery, considering the global scenery of malnutrition, the recognition of this global syndemic, so malnutrition and the climate change, they have determinants, and the recognition of primary care as a privileged locus to articulate actions for food and nutrition and health, and the recommendations, global recommendations about the importance of the universal coverage of actions in food and nutrition in the health system. For such, for the strengthening of the actions for food and nutrition in primary healthcare, it is necessary to recognize that malnutrition impacts about the health conditions and nutrition of the population, and that the health systems impact the climate change in a global level. I foment the construction of food systems that promote healthy feeding in order to guarantee policies and strategic that do not affect the health conditions of people and the planet. I incentivate to these food environments which are sustainable in schools, health services, work, cities, amongst others. Of the financing and fomenting of studies, researchers in the area of food and nutrition. The elaboration of policies, local policies of food and nutrition based on national policies, consolidation of the public policies towards primary care, especially the strategies to promote health, prevention of diseases, and amplifying of access to the population to the care, integral care in health. Adequate financing and sufficient financing for the actions of food and nutrition in the health sector, especially in primary health care, with the inclusion of indicators of food and nutrition as a condition for this financial bringing of, and also for these multi-professional teams to assure the universal offer of actions and food, and executing actions were pertinent to situations and necessities of the community, with the conclusion of the professional. Strengthening of the articulation into sectorial circulation to guarantee the right to adequate food in view of the nutritional insecurity scenario and the role of mediated to primary healthcare facing intersectorial actions and the participation of people to incite in this determination to promote health and reduce inequalities, to strengthen the responsibilities, federative responsibilities in the municipal, state, and federal levels, and the integration amongst all spheres of management in formulating and implementing the agenda in the policy of food and nutrition, prioritizing in all essential levels of preventive actions and all the ways of malnutrition, like the prioritizing of strategies towards groups in vulnerability situation to guarantee equity, strengthen the food and nutritional vigilance as a strategy to care and management the food actions and nutrition, invest in the amplifying of the actions of food and nutrition offered to primary health care. We focus in vigilance, promotion, and care, like in the use of tools to have supported health care. So for this permanent action and formation in services in food and nutrition within interprofessionality, like it is a stimulus and formation of leaderships in food and nutrition, guarantee the participation, social participation in the formulation of strategies of food and nutrition and health, and finally, engage community engagement to make it possible to raise awareness and develop actions for the promotion of health in food and nutrition. This is the second letter, Brasilia letter, that consolidates a little bit of our discussions. Thank you very much to you all who are here with us. I'm going to pass the floor to Gabriela now to finish with our seminar. Thank you, Dr. Gisele. In this moment, we reached the final part of our seminar for food and nutrition in the primary healthcare. We reinforce our wish that the debates were brought here configure as a space of exchange and reflection about the challenges for the advancement of the actions for food and nutrition in primary healthcare, and make it possible to amplify the universal coverage for actions in food and nutrition in the healthcare systems. We hope that the ideas and words that were shared here can gain a body in many territories in the many countries with the aim to guarantee better conditions of food, nutrition, and health to people. We remember that the event will be available in the website of PAHO and OPAS. Always when you want to return to the issues that were arose here, we thank very much for you all who were here with us during these 3 days. In the name from the Ministry of Health from Brazil and PAHO, we thank for all of you who were here. And soon, the second letter from Brasilia will be available in the website of this seminar, nutriçãoaps.com.br. Remember, for those who participated in all the 5 the continents of the world. The registry had more than 50 countries and more than 5,000 people. We wish a great night for you, and we leave here once again our thank you.
Recording stopped.